Okay, so Assalamu alaikum everyone. I hope you're all doing well, inshallah. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student, and inshallah, for today, I'll be going over the renal crash course, inshallah. So the renal crash course will be a two-part session, inshallah. Today, I'll be going over nephrology, and inshallah, the second session on Tuesday, I'll go over urology, inshallah, in total. Now, for nephrology, what I'll cover, inshallah, for today are all the glomerular and the, nephrotic and nephritic syndromes, plus all the tubular diseases and all the electrolytes, acid-base disorders, all the pharma drugs, inshallah, all will be covered today, inshallah. So just like all my sessions, this will be a very interactive session. And this session will be more me explaining concepts, especially when it comes to clinical nephrology. And then we apply, inshallah, what we learned afterwards. So without further ado, we will start now. Like when we look at the normal kidneys, we need to look into, firstly, what is the main function of the kidney. So the main functional portion of the kidney, we all know, is the nephron. So the nephron, we can kind of divide it into two structures. We have the glomerulus, and then we'll have the tubular structures. So in the glomerulus itself, what's the main function of the glomerulus? You guys tell me. Main function. Filtration. So blood will go to the glomerulus, will filter all the solutes, all the blood into the kidneys. Okay? How does this happen? We'll have the renal arteries. Yes, so we'll have the renal artery that will go into the kidneys, divide into the segmental branches. From the segmental branches, it will go between the lobules, which is all of this, then an arcuate vessel, then interlobular, then it will go as an afferent arteriole into the glomerulus. Now, in the glomerulus itself, as we said, its main function is filtration. So blood will come from here to here. This space over here is the Bowman's space or the Bowman's capsule. Tamam? So when it goes through this space or these barriers, it has to go through three layers. Number one is the endothelium. Number two is the basement membrane. And number three is the podocytes. Okay? So it goes through all three of these to go into the glomerulus or the Bowman space, and then it goes to the tubular system. This is the functional portion of the glomerulus. Now, we have a lot of diseases that will affect this function specifically. It's either we have inflammation that will target this barrier and will cause blood to go into the tubular system, or we have a defect of the barrier itself, some deposition happening there, or any disruption to the charges of this barrier. This will cause molecules that we don't want in the urine to go into the urine. Tamam? Now, when we have these two sets of diseases that will go into it, we need to have a way of diagnosing it. The gold standard way, usually, however, it's not usually used nowadays, is kidney biopsy. Why do we need kidney biopsy? It's to just see what's happening in the kidneys, okay? Now, in the kidneys itself, this is what you'll see. You'll see the glomeruli, which are these tufts of capillaries, and then you'll have all the tubules around it, okay? You don't need to identify which one is distal convoluted tubule, which one is proximal. This is all first here. What I want you to remember is when you see this type of picture, you need to be able to count the glomeruli, okay? Why is that so? Is because there are certain diseases that you differentiate based on the number of glomeruli that are affected, okay? This is how we name it, either focal or diffuse, okay? Focal glomerulonephritis, which means it affects less than 50% of the glomeruli on a biopsy, okay? And we'll look into an example. If I say diffuse, that means it affects more than 50% of the glomeruli when you take a biopsy. Then we look into this specific glomerulus itself. This is a normal glomerulus. You can see this is the Bowman's capsule. It has two epithelium, the parietal and the visceral epithelium. The visceral is the podocytes. And you can see a lot of RBCs, these red cells, which is because it's capillaries, okay? Simple. Now, another thing you do when you're diagnosing glomerular diseases is you need to do electron microscopy. And you need to look into what changes are occurring at the filtration barrier. So we have, as we said before, three layers in the filtration barrier. The first layer is the endothelium, which comes from the blood itself. Now, the endothelium has fenestrations, pores, which are large enough, which will allow molecules to go through it. Then we'll have the basement membrane, and then we'll have the visceral epithelium, which are the podocytes. Now, what's maintaining the filtration barrier itself is two things. Number one is the podocytes. The podocytes, the pores between the podocytes are very tiny, very small. It won't allow any macromolecules, big molecules, to pass through it. What are examples of macromolecules? Proteins, which is very important, and RBCs, big RBCs. Okay? These are very important. And other things like, for example, lipids won't be able to go through. And you'll have, for example, some blood, like cytokines and some other things such as antithrombin 3, just for you to remember. It won't be able to go through. Okay? Number two is the basement membrane. Okay? Why and what about the basement membrane is this thing, which is the proteoglycan heparin sulfate, which is the composition of the basement membrane. Why is this important? This is negatively charged. Okay? If it's a negative charge molecule, it will repel negative charge molecules. Okay? From basic physics. Proteins and these larger molecules are negatively charged, so it will repel it. Okay? Hence why you will not get proteins, you will not get lipids, you will not get some stuff like antithrombin 3 in the urine. If you do, that means there's a defect in the filtration barrier. Okay? So this is what's happening at the electron microscopy level of a normal glomerulus. Then we go into renal tubules. Okay? So we're done with filtration. Now we go into the other functions of the kidneys or the nephrons, which is going to be reabsorption, excretion, secretion of different solutes, of different molecules. I won't go into the details of every single part of the tubules because this is stuff we learned in first year. However, I'll go through just some important bits that is important clinically later on. Number one is in the proximal convoluted tubule. We know from first year that in the proximal convoluted tubule, you'll have a reabsorption of a lot of molecules, such as glucose, urea, uric acid, amino acids, and a lot of the electrolytes. Okay? This is important. Why? One main electrolyte I want you to remember is bicarbonate at this level. Okay? Bicarbonate, most of it will be reabsorbed at the level of the proximal convoluted tubule. Why is this important? Is if you have any defects that is affecting the proximal convoluted tubule that will affect the absorption of bicarb will go into the urine. It will not be reabsorbed. So what acid-base disorder will this cause? If bicarb is getting washed into the urine, metabolic acidosis. You don't have bicarb anymore that's getting reabsorbed. It's just going to go into the urine. So you'll have metabolic acidosis. We'll go into one tubular, high-yield tubular defect that will affect this. And it's the only one that's going to cause metabolic acidosis. Now you know why. Okay? And we'll go into it later. Then we have the ascending loop of Henle. All I want you to remember about it is this receptor over here. This receptor is the sodium potassium 2 chloride. What drug binds to this receptor and blocks it? Loop diuretics. Good. Then we'll have the distal convoluted tubule. In the distal convoluted tubule, we'll have one major receptor, which is a sodium chloride channel. What drug binds to this? Or class of drugs? Thiazide, diuretics. Good. Now we go into the collecting tubule. Now the collecting tubule is a main site where you have ADH acting onto the kidneys to affect obviously a reabsorption of water mostly. So here you'll have a lot of the ADH receptors. Another major receptor that you'll have here is aldosterone receptors. So you have medications that will basically are potassium-sparing diuretics that affect the aldosterone mechanism. So for example, you'll have spironolactone, eplerenone, and whatnot binding to the aldosterone receptor, blocking its function. Then we'll have epithelial sodium channel receptor blockers, which are, for example, amiloride, that inhibits the sodium reabsorption, hence causing diuresis. Okay? This is the basic functions of the tubules. You don't need to go into very specific details. However, you do need to know where the receptors are for pharmacology. Okay? So that's basically this slide in a nutshell. Now, When you have a patient who has a renal disease, okay, a disease affecting the kidneys, you have a certain set of investigations that you would want to do in order, okay? Obviously, once you have a patient, you take history and physical. In your context of a lot of these glomerular diseases, this will help you so much, just knowing the basic history. And I'll explain why in the clinical scenarios that I'll give you. Then you need to do certain investigations. Now, I'll give you a certain, like, for example, disease state of the kidney, and you tell me which of these you want to order, okay? So number one, if a patient has acute kidney injury, okay, no matter what the cause is, what do you want to order from all of this? تمام. So the answer is all of these electrolytes. Then from here, do you want to order GFR for acute kidney injury? Yes or no?
No. No.
No, it's not going to help you in acute kidney injury. What will help you is creatinine. Okay? You'll see a rise in creatinine that occurs in acute kidney injury. What else do you want to order? BUN. Okay? What do you want to do with both of these? Is you want to see the ratio of blood urea nitrogen and creatinine to assess what type of acute kidney injury this patient has. I'll explain this in a separate slide later. But basically, blood urea nitrogen is filtered by the kidney and it's reabsorbed. Okay, so it will be higher level in the blood than creatinine. Why? Creatinine is filtered and excreted directly. It won't be reabsorbed. The normal ratio that I want you to remember is 15. This number will help us determine what type of kidney injury is occurring in the patient, whether it's pre-renal or intrarenal. This is the number, or these two variables you need to look into. And in any case of acute kidney injury or even chronic kidney disease, you need to always order these electrolytes to see what type of electrolyte imbalances is occurring in the patient, and obviously anion gap and the acid-base stuff. However, if you have a patient with chronic kidney disease, which one do you want to order to assess what stage the patient's at?
EGFR.
صح, good. EGFR. EGFR will help you stage the patient on what stage of chronic kidney disease he's at. Okay? And we'll talk about all these stages later on. This is the basic renal function test that I want you to remember. Obviously, there's a lot of acid-base stuff. Obviously, there's bicarb, but you also need to do PCO2 and all that stuff that we'll assess and talk about later on, inshallah. Okay? Now, what's next? Now you assess the blood. What do you want to assess next? It's in the kidneys. What's the function of kidneys? Produce urine. So what do you want to do? Assess urine. Okay? Simple. Now, in the urine itself, you can look into two things: the physical properties of the urine and the chemical properties. The physical properties will look into stuff like how much urine is the patient producing, which is important. The appearance of the urine itself in terms of it's clear, cloudy, turbid, and so on and so forth. The color of the urine, the odor, any deposits in the kidneys itself, and the pH. So now we'll look into the volume. The normal volume is 0.4 to 2 liters per day. Now, if it's more than 2 liters, this is what we call polyuria. If it's less, then this is oligouria, okay? So when do you see polyuria? Is, for example, diabetes, whether it's mellitus or insipidus or psychogenic polydipsia. The patient's drinking a lot of water and peeing a lot, okay? This is polyuria. In oligouria, it's the opposite. The patient is not urinating enough, okay? Now, I want you to remember the terms for both of these because when we talk about acute tubular necrosis, there's two different stages that will be differentiated by these two values, okay? I'll explain it later. Appearance, it's not really important in intrarenal diseases. It's more important when we talk about infections. Any infections in the kidneys or the urinary tract will cause a cloudy urine, okay? Then the color. The color is affected by a lot of things. If the patient has jaundice, or any liver disease, it will become yellow, green, okay? If it's red, it could be indicating blood, and it's usually gross hematuria. I'll explain what that means later. And then it can be affected in any ways depending on what disease the patient has. This is not as important for you to remember. Odor, again, same thing. It's affected by what disease the patient has. Characteristic stuff, like for example, fruity, just basically tells you that the patient might have diabetic ketoacidosis. The rest, not important for you to remember. Deposits, not important. Again, and also pH, you can look into the pH of the urine if it's acidic or alkaline, okay? But obviously, there's better tests that we do to check for acidic versus alkaline urine. Now, this is what's more important, is the chemical analysis of the urine. We do a urine analysis to see the composition of the urine itself, okay? So now we'll go over it one by one. Number one is protein, okay? Are you supposed to see protein in the urine? A lot of protein in the urine?
No.
No. What is the cutoff number that I want you to remember is 3.5, okay? 3.5 is the magic number in renal, okay? If this patient has more than 3.5 grams per day, this is a certain syndrome of diseases. If it's less than this is another syndrome of diseases, okay? If there's a lot of protein in the urine, that tells you that there's something wrong with the filtration barrier of the kidney. This is what we call nephrotic syndrome, okay? Now, some other diseases, such as glomerulonephritis or nephritic syndrome, will have proteinuria, but it's less than 3.5, okay? You'll also have cancers. So, for example, multiple myeloma, if you remember from Hem-Onc, I said that you'll have Bence-Jones proteins in the urine. This is the protein that's causing proteinuria in multiple myeloma, okay? Glucose, you're not supposed to have any. Why? Because all of it will be reabsorbed in the proximal convoluted tubule. So if you have more than the maximum amount that can be reabsorbed, you'll have glucosuriuria, which is seen in diabetes. Next is ketones. Again, you're not supposed to see it. If you see it, ketoacidosis, okay? Nitrite, we'll talk about it in the next session when we talk about UTIs and pyelonephritis, but you have two specific tests that you do in a urinalysis for a UTI. Nitrite and leukocyte esterase. Nitrite will tell you that this patient has a UTI due to a gram-negative organism, okay? Leukocyte esterase will tell you that this patient has pyuria, which means there's WBCs in the urine. We'll talk about this in more detail, again, next session, inshallah. Bilirubin is not important for your block in this case, and urobilinogen. If you see it in the urine, don't worry about it, but you might see it in the case of hemolytic anemia or in liver diseases itself. Then you have blood in the urine. This is important. Blood in the urine, we call it hematuria. Now, there's two ways we can describe it. Macroscopic versus microscopic hematuria. If I tell you in the clinical scenario that I can see blood in the urine, is this macro or micro?
Macro.
Macro, good. This is macroscopic hematuria. When would you see this? Is anything affecting the track of the kidney? Cancer, stone, infection, and so on and so forth, okay? Microscopic hematuria means that the patient cannot see that there's blood in the urine. However, when you do a urinalysis, you can see RBC plus 3, okay? Or you'll see RBC casts. This is indicating that there's something wrong at the level of the nephron, specifically the glomerulus, okay? So this is why we see microscopic hematuria in the glomerular diseases, okay? And I'll explain why exactly in a bit. Tamam? Now, the next set of things we order when we do a urine analysis is casts. Now, how do casts form? So casts form because of a buildup of a certain substance, whatever these substances are, the ones that are in the screen, it builds up in the distal convoluted tubule and the collecting duct. It builds up there. What happens when you initiate urination is it pushes all of these substances into the urine. These substances are clumped up, okay? So it will appear as casts. Now you have different sets of casts that develop due to certain diseases. Okay, let's talk about them one by one. Number one is hyaline casts. Hyaline casts are very non-specific. It's basically when there's this one protein, and that's in the tubular cells itself. It's called Tam-Horsfall proteins. If it accumulates in the distal convoluted tubule or the collecting duct, if it accumulates there and it gets pushed away by the urine, it will appear as hyaline casts, these clear casts in the urine. These are non-specific. Okay, so if you see hyaline casts, it could be another sign of ATN, but it's not that specific. What's more specific in ATN, acute tubular necrosis, are these granular muddy brown casts. And this will come as a question, whether it's in a scenario and they give you this, or they'll ask you like this picture and you know this is ATN. What is granular cast or muddy brown cast? Are necrotic tubular cells. What happens if it goes through necrosis? It gets sloughed off into the lumen of the tubules. So what's going to happen is it's going to push away into the urine and it's going to appear as these granular casts. Okay. The next thing is RBC casts. The RBC casts, because of a buildup of red blood cells in the tubules itself, because of glomerulonephritis, nephritic syndrome, it will appear as these RBC casts. Simple. WBC casts, again, buildup of white blood cells in the tubular system. And this is indicating of infection in the kidneys itself. Okay, so either this is interstitial nephritis or pyelonephritis. Now, more specifically, is if you see these WBC casts plus eosinophils in the cast itself, what type of nephritis is occurring in this patient? Do you know? Acute interstitial nephritis or acute tubulointerstitial nephritis. Excellent. I'll talk about this later. Okay, good. Now, as I said, if you have a defect in the filtration barrier, okay, that's allowing macromolecules to be filtered into the urine. So you'll have proteins in the urine, you'll have lipids in the urine. If lipids build up in the tubules, it will appear as fatty casts. And this is in nephrotic syndrome. So it will appear as these multi-cross deposits in the urine itself. Okay. Why do you see lipids or fatty casts in nephrotic syndrome? Is because, again, you have loss of charge, loss of the filtration barrier. This will allow lipids to go into the tubules. Simple. Then we have waxy casts or the broad casts. Again, it's not specific and don't worry about it. Now, if you have no cast but hematuria, when it's gross hematuria, then you suspect one of these two. And then has no cast but has pyuria, you expect a lower urinary tract infection. Okay? These are the casts. These casts will support your diagnosis. Okay? So usually, in a case of a nephritic syndrome, they'll tell you that the patient has RBC casts. Usually, in a case of nephrotic syndrome, they might tell you this patient has fatty casts. If they're testing you on tubulointerstitial nephritis, they will tell you you'll have white blood cell casts plus eosinophils. Okay? And then same thing with ATN with the granular casts. These are hints to any question you get on all of these diseases. Okay? And I'll practice with you guys, inshallah, as we go through this session. Now we go into the diseases, okay? So the first set of diseases that I'll look into is glomerular diseases. We'll go through all the nephritic, nephrotic. Again, to repeat, we have these three layers in any filtration barrier in the glomerulus. The endothelium, which is lining the blood vessels. You'll have the basal membrane, which is negatively charged. And you'll have the visceral epithelium or the podocytes. Okay? This is maintaining a normal filtration barrier. Now, what happens in nephritic syndrome? As you'll see, when I describe each of these diseases, all of them will have something in common, which is antibodies. Okay? Most of them will have some certain set of antibodies attacking the glomerulus. What will happen with antibodies damaging the glomerulus? Inflammation. So it will destroy the barrier. What will go into the urine because of inflammation? WBCs, yes, but very importantly is RBCs. So these patients will have hematuria. The proteins, not a lot will go into the urine in this case, so it won't have proteinuria that's above 3.5. Okay? The hallmark is hematuria. So nephritic syndrome, what's happening is an antibody-mediated damage of the filtration barrier. Okay? It usually affects below the endothelium or some of the endothelial structure, less commonly the epithelium, which is the podocytes, um, and you can also affect the basement membrane. Usually it deposits subendothelial. Why, you might ask, is it's closest to the blood. Okay, so you'll see a lot of these nephritic syndromes when I describe the deposits, it's subendothelial. Okay, because it's right next to the blood. Some of them will go through and cause subepithelial. It's not absolute. Okay. And in nephritic syndrome, they will have hypertension as well. This is also a very important thing. Now, because of this proteinuria that's occurring, it's not as much as in nephrotic. There's not a lot of proteinuria. So will patients with nephritic syndrome have severe edema? No. If I tell you a patient has severe edema, you think nephrotic. If I tell you this patient is young, hypertensive when they didn't have hypertension, and has hematuria with RBC cast, nephritic. Okay? That's basically nephritic syndrome. Now, nephritic syndrome has many sub-classifications of diseases, and we'll get two of them one by one, inshallah. Okay? Now, in nephrotic syndrome, it's somewhat different. In nephrotic syndrome, you have a defect in either the podocyte or the basement membrane. What's happening here is either you have damage to the podocytes, where you remember the foot processes, it becomes flat. So the pores itself will no longer be as functional anymore. It will allow proteins to go. Okay. Will it allow RBCs? There's no damage here. So RBCs won't go. So you won't have that much hematuria, but you will have proteinuria, a lot of proteinuria. Number two is you'll have loss of charge in the glomerular basement membrane. Why? Is you'll see that a lot of these deposits are gonna deposit where? In the membrane. Okay, membranous nephropathy, and all these we'll go into it. The membranoproliferative and so on and so forth. It will deposit in the membrane, so it will cause loss of charge in this membrane, hence causing proteinuria. Okay. Now, is it only proteinuria that's going to happen? No. They'll also have hypoalbuminemia, which basically means that they'll have loss of albumin into the urine, and they'll have low albumin levels in the blood. What's this going to cause? It will cause low oncotic pressure in the blood, which will cause edema. Okay? So these patients typically will present with severe heavy proteinuria with peripheral edema. Now, peripheral edema is not specific, and lower leg edema is not specific. Something in nephrotic syndrome that's kind of specific is facial edema. Okay, I don't know if they mentioned this to you, but periorbital, around the eyes, exactly. That type of edema is very specific to nephrotic syndrome. Okay, now they also have basically lipids that will go into the urine as well. Okay, so that's why you had fatty casts. Now, very important as well is you have loss of antithrombin 3. Okay, what is antithrombin 3? It's an anticoagulant. Okay, so if you have loss of antithrombin 3, will your blood be more? Yeah, it's hypercoagulable. Good. So you will be in a hypercoagulable state. So you might present with DVTs and so on. So in patients with nephrotic syndrome, or more specifically, one specific type, you give them anticoagulants as a prophylaxis so they don't develop clots. Okay? Good. Now, something to remember is a lot of these diseases that we'll discuss that is nephritic or nephrotic overlap. Okay? They may overlap. So don't get confused. If I say, for example, in SLE, it can present as a mixed nephritic nephrotic. Membranoproliferative glomerulonephritis will present as both. Okay? So they may overlap. But what's important is you need to identify each of these diseases that will go into it. Okay? Now, before I go into the diseases, I just want to describe some terms so it's easier to describe a lot of these diseases and what's occurring. As I said before, when you take a biopsy of the kidney, you'll see multiple glomeruli. You need to count how many glomeruli are affected. If it's less than 50%, what do we call this? Focal. If it's more than 50, diffuse. Simple. Now, within the glomerulus itself, if there is hypercellular glomeruli, whether this is, for example, mesangial proliferation, or there's hypercellular because of inflammatory cell, we call this proliferative. Okay? Membranous means anything affecting the basal membrane. Simple. Okay? Now, we have primary diseases and secondary diseases. Primary diseases are primary disease of the glomeruli itself. This patient does not have any other disease. They just presented with isolated minimal change disease or isolated proteinuria. This is what we call primary disease. And this is usually idiopathic. We don't know why it happens with these patients. Okay? Or there's some receptor issues that we'll describe later. Then we have secondary glomerular diseases, which is a certain other disease causing the glomerulonephritis, causing the kidney disease. So for example, SLE, diabetic nephropathy, malignancies, drugs, all these things causes secondary disease. Okay? Are these terms clear and all these concepts clear before we go into each disease? Now it's going to go a bit faster. Tamam. Now, as I mentioned before, in nephritic, what's happening is you have antibody deposition causing inflammation. Majority of the deposition of the antibody is subendothelium. Okay? Why, as I said, where are the antibodies coming from? The blood. Where is the blood? It's right here. So what's the first thing it can go through? Subendothelium. Easy. So most of these deposits I will describe as subendothelium. Okay? And this is in most cases of nephritic syndromes. There's some that causes subepithelial. It's just a lot more rare, but I'll mention it to you if you need to identify it. Next thing is it could affect the membrane itself. And this is in one disease. Okay, and I'll explain it later. Now, lastly, is so you have subepithelial that may happen, as you can see here. Again, it's a lot more rare. Now we go into the disease. Now, you have this child telling you that 2 weeks ago, I had upper respiratory tract infection, pharyngitis. Today, the patient woke up with red-colored urine. What is this disease? Post-streptococcal glomerulonephritis or post-infectious glomerulonephritis. What's the organism causing it? Strep pyogenes or group A strep. Good. Now, group A strep has certain nephrogenic strains that I want you to remember, which is what numbers? There's 3 strains, 1, 4, and 12. Good. Remember these. 1, 4, and 12. Perfect. Now, when you are suspecting a patient with post-streptococcal glomerulonephritis or post-infection, what antibodies do you want to order in the blood? ASO, anti-streptolysin O, and you have another one, which is usually in anti-DNase B, sorry. Good. So you have a patient who presented with pharyngitis, okay, or dermatitis, okay, that later on presented with cola-colored urine, okay, and maybe hypertension because it's a nephritic syndrome. So this is post-infectious glomerulonephritis, and it's usually caused by, again, immune deposition, antibody deposition, which is anti-streptolysin O or anti-DNase B, into the glomerulus. Where is this deposition? In this case, it's a bit of a rare finding, but where do you see it? Is it subendo or subepi? Subepithelial, because this is the epithelium. You can see the podocytes, and it's subepithelial. Okay? Now, when you're assessing these glomerular disorders, you need to do 3 things. Number 1, light microscopy, electron, then immunofluorescence. So in light microscopy, what do you see? Hypercellularity. Good, that's it. Electron microscope, we already mentioned that you would have subepithelial deposits. Now, what about, or humps, good. What about on immunofluorescence? What type of pattern do we see? Granular or starry sky appearance. Perfect. Good. This is post-infectious glomerulonephritis, or PSGN, which is post-streptococcal glomerulonephritis. Okay. Now, this is one of the more common ones that occurs in children. It's usually in children. It's very good prognosis if it happens in children. If it happens in adults, it's poor prognosis. Just remember that. Okay. Now, another side note is treating the pharyngitis with antibiotics does not eliminate the chances of this happening. It's not like, if you remember, rheumatic heart disease. If you treat the primary disease, which is pharyngitis, when it first happens, it prevents the rheumatic heart disease. In this case, it doesn't. Okay, so that's basically PSGN in a nutshell. Okay. Now, you have another patient who had a GI infection or a upper respiratory tract infection, later on developed knee pain, GI pain, and hematuria with hypertension. What does this patient have? IgA nephropathy. Good. So, IgA nephropathy, okay, can be an isolated disease. It happens on its own, but it's usually associated with an infection. An infection later on has a reaction to cause IgA nephropathy. Now, what are the infections that usually causes this? Is upper respiratory tract infection and GI infection. Do you know why only these two diseases or only these two infections? Because of mucosa. Good. Perfect. What is the antibody lining these mucosal surfaces? IgA. So because of these mucosal infections, which is upper respiratory tract infection or GI infection, they will have IgA attacking the kidneys itself. Okay? So this causes IgA nephropathy. Now, IgA nephropathy is one of the most common causes of glomerulonephritis in adults. Okay? Now, you might ask is how do you differentiate this from post-strep? Okay? Because it can happen in children as well. So I want you to remember two things. I don't think they'll test you on this at all, but in case, in a scenario, you'll know. Is in post-strep, it happens 2 weeks after the strep infection. In IgA, it's usually 5 days. It's more rapid. That's number one. Number two is in IgA nephropathy, they'll come with other symptoms. Okay, they might have an overlapping symptom, a syndrome called Henoch-Schönlein purpura, which will come with skin lesions, knee pain, and GI symptoms. The vasculitis, yes. Okay, so this differentiates it. On histology, you need to know how to differentiate it. Here, do you see hypercellularity as much as PSGN? No. What do you see here? What's proliferating? You'll have mesangial proliferation. Good. Another thing is if you look at what type of deposits here, it's mostly IgG, IgM, and C3. Here it's, from the name of the disease, IgA. They will tell you that the deposition is IgA in the question, and you'll know it's IgA nephropathy. But again, to recap IgA nephropathy, it's usually after a GI or upper respiratory tract infection. Very common in adults. It has good prognosis. You just treat with ACE inhibitors or ARBs. And it's more rapid after an infection, so 5 days after an infection. And it usually also has other manifestations such as joint pain, palpable purpura, and all these things. And it's IgA mediated, so if you do immunofluorescence, you'll only see IgA deposition, not IgG and C3 like in PSGN. And if you do light microscopy, you can see mesangial proliferation. This differentiates the two diseases. Tamam? Now, there is a 4-hit theory of IgA nephropathy. So I will not go into detail, however, you might get questioned on it, but just for you to know what this slide means. Is in tissues that have galactose deficient IgA, you might produce IgA antibodies against glycan. Okay, where is glycan in this whole story? It's in the basement membrane. Okay, so what will happen is you'll develop IgA against that glycan that is in the basement membrane. That's the whole purpose of the slide. is that you will produce IgA antibodies against the glycan. Where is it? Where is the glycan? In the basal membrane. So you have formation of IgA immune complexes that will go to this glycan and will cause all the inflammation, cell apoptosis. Okay? Will you get tested on this? I highly doubt, but fair game. Okay? So yeah, this is the forehead theory of IgA nephropathy. Now you have this child who, very similar, had upper respiratory tract infection 5 days later, presents with palpable purpura in the lower legs, okay, and joint pain, GI pain, and then you can see hematuria. And then IgA deposits. HSP, Henoch line purpura or IgA vasculitis. It's the same as IgA nephropathy. It's basically like almost the same entity, okay? So you don't need to go into in-depth detail of what's the difference between them. Okay, it's basically whatever happens in the kidneys, it's exact same. Okay, but it has other manifestations such as the palpable purpura. Okay, it's a very common description for HSP. Tamam? Now, you have a lot of sets of diseases that will cause what's happening in this patient, which is very rapid deterioration of renal function. Rapid deterioration, severe deterioration. What is this called? Rapidly progressive glomerulonephritis. Good. Now, what I want you to remember is in histology, what is proliferating, visceral or parietal epithelium? Parietal epithelium. Good. The parietal epithelium is proliferating and compressing the glomerulus from outside. So, of course, the glomerulus will no longer function as the patient deteriorates. Okay, this is a very bad disease. It has a very poor prognosis. RPGN is an entity of other diseases. So other diseases can cause RPGN, okay? Now, how do we tell the difference of what's actually causing the RPGN? You guys tell me. What is one thing I will do that will tell me what type of RPGN this patient has? Immunofluorescence, good, okay? So immunofluorescence will show me what type of pattern is happening in the RPGN, whether it's granular, linear, or nothing, okay? If it's granular, then we can have a set of differentials. If it's linear, we have a set of differentials. If it's pauci-immune or there's nothing on immunofluorescence, then we have a set of differentials. Tam? We'll go over it one by one. In this case over here, in this RPGN, rapidly progressive glomerulonephritis, what type of pattern do you see? Granular pattern. So, what set of diseases can cause granular pattern? Just throw me diseases in the chat. Post-infectious glomerulonephritis, SLE, FSGS, all of these glomerulonephritis that we talked about, IgA, if it develops and deteriorates or progresses, it can form RPGN. Okay, and the hallmark is a granular pattern on immunofluorescence. Okay, that's all you need to know. Now, very importantly, and it's done by immune complexes, obviously, because of the antibodies and stuff, is this patient. This patient tells you that they are coughing out blood and there's hematuria. What does he have? Goodpasture syndrome, which is what type of pattern? Linear pattern. Good. So it's linear pattern on immunofluorescence. It's what's causing the RPGN in this case. And very importantly, the patient will have two symptoms. I don't know why balloons are showing up, anyways. Hemoptysis and hematuria. Okay? Remember this in a scenario. This is anti-GBN. It's basically antibodies, type 2 hypersensitivity reaction against the basement membrane. Okay? And it's causing a linear pattern. And that's it. Now, what if you see nothing at all? What do we call this? Pauci-immune, and it's mediated by ANCA-positive vasculitis. What are the three ANCA-positive vasculitis? We did this in CVP and in MSI. Wegener's, microscopic, and eosinophilic one, which is Churg-Strauss. Good. These three. Can affect the kidneys and cause immune RPGN. Okay. This is basically the rapidly progressive glomerulonephritis, basically. Now you have this patient over here. This patient over here maybe had hepatitis C, HIV, and then presented with a mixed hematuria and proteinuria. And when you do silver stain, you see this appearance. Membranoproliferative glomerulonephritis, MPGN. Now, MPGN is one of the mixed nephritic nephrotic syndromes, just so you guys are not confused, okay? It's usually overlaps between them. Now, very importantly for you to remember is when you do silver stain, what do you see here? Tram track appearance, okay? Why is this so? So MPGN has two types, okay, depending on where the deposits are, okay? So you have type 1 over here, which is affecting where? Where are the deposits? Subendothelial. Good. And then what about this one? Where is the deposits? Intramembranous. So if you really want to think about it, is what if you have deposits that's happening inside the membrane? It will cause the membrane to split. So it will form tram tracks. Okay? This is just my way of remembering why tram track happens in MPGN. Okay? But basically, it has two types. Type 1, which is the subendothelial deposits. It's usually mediated by IgG and C3 and all these things. And then type 2 is the dense deposit disease, which deposit intramembranous. What do you need to know about all of these things is you need to just know how to identify this. Is if I say there is intramembranous deposits in a patient with, for example, nephritic syndrome, MPGN. Okay? And you need to know this picture well, that it's intramembranous. Okay? So that's basically MPGN. Now, when does it occur? There's a primary MPGN, which is idiopathic. It happens on its own. And then it can be secondary to things like hepatitis C, some certain malignancies, alpha-1 antitrypsin deficiency. SLE is more in other things. But it can overlap. Okay? So that's basically that. So these are majority of the nephritic syndromes. Now we go into a nephrotic syndrome. Now in these two pictures, do you see anything wrong? Yes or no? No. Okay. I'll ask one question. What's in the tubules over here? Lipids. Good. Perfect. These are lipids in the tubules. So what's it telling you? Is it nephritic or nephrotic? Let's start from there. Nephrotic. Now, you have a patient, a child, with massive proteinuria. Okay? Nothing else. What do you suspect this child has? Minimal change disease. You do light microscopy and immunofluorescence, completely normal. If you do electron microscopy, before I show you, what will happen? What will you see? Effacement of the foot processes. Good. So this is, again, the electron microscopy. This is the endothelium. We could see some RBCs here. This is the very thin basement membrane. And then you can see some foot processes. Here, do you see the foot processes as well? No, it's just flattened. Okay. So hence, it loses its function. And then you'll have, obviously, proteinuria. Now, in these patients, it's the most common one that happens in children, minimal change disease. It's very good prognosis, very easy to treat. What will you use to treat? Give me the drug. Steroids. Give the patient steroids, they'll recover very easily. Okay, good. They'll present as massive selective proteinuria. What does that mean? Selective proteinuria is, for example, if you do in-depth urine analysis, you'll see only albumin, for example, elevated. Okay, good. Perfect. So that's basically minimal change disease. Okay. Now, you have this patient who is obese, has diabetes, could be someone who is taking heroin as well, presenting to you with proteinuria and edema and a hypercoagulable state. This is FSGS. Good. So if you look at the glomeruli, is it affecting more than 50% or less than 50%? Less than 50. Why? Is because it's called focal. Good. Now, in the glomerulus itself, is it affecting the entire glomerulus or only a segment of it? Segment. Good. Perfect. So it's only affecting a segmental portion of the glomerulus. Now, what will you see in the actual glomerulus is it's hyalinosis that's occurring in only a portion of the glomerulus. This picture will come in some form of your exam, one of these two. طيب, one of these two. This because it will tell you that it's focal and segmental, because you can clearly tell this glomerulus is not as affected as this one, and then you can clearly tell that this part of the glomerulus is affected more than this one. This is a very clear image of the disease. Okay. Now, when does this usually occur? It can be idiopathic, and it can be secondary to something else. Just some demographics for you to remember is it's usually described in an African American Hispanic patient, and it's usually described as an obese patient with diabetes, and heroin is associated with it, and I think some other diseases as well. For example, sickle cell is associated with it. Yes. So that's in FSGS. Okay. Now, if you do here electron microscopy, what will you see? Effacement of the food processes. Good. Okay. Perfect. Now, how do you treat this? Very simple. Is it's mostly secondary to other things. So what do you want to treat? The underlying cause, whatever the patient has, and then it'll fix the issue. If it doesn't, you can give immunosuppressants. That's how you treat FSGS. Okay. Now, how about here? You had a patient who is, let me give you a scenario, who is osteoporosis, and taking a form of bisphosphonates, pamidronate to be specific. What's happening here? You do staining, and it's only staining the visceral epithelium, to give you a hint. This is collapsing glomerulonephritis, or collapsing glomerulopathy. Okay. Now, this is a variant of FSGS that occurs in certain sets of patients with either who are taking drugs, had viral infections, or what's it called, ischemia of the kidneys. Okay. Now, this, contrary to rapidly progressive, it's basically proliferation of the visceral epithelium. In the case of RPGN, it's the parietal epithelium that's going to compress the glomerulus. In collapsing glomerulopathy, it's the opposite. It's the visceral that's going to start proliferate. Okay, that's all you need to remember for this. It's caused by three things: either ischemia, viral infections, and then certain medications, and it's commonly pamidronate, which is one of the osteoporosis medications. Okay. That is the collapsing glomerulopathy. Now you have this patient who has this proteinuria, edema in a middle-aged patient. Maybe had HIV, hepatitis, SLE, membranous nephropathy. Good. Okay. This is membranous nephropathy. Now, membranous nephropathy usually is in a middle-aged patient, okay, presenting to you with nephrotic syndrome. They'll have hyperlipidemia, they'll have edema, facial edema, and they'll have proteinuria obviously in the urine, and they will be in a hypercoagulable state. Okay? So now, if they had an underlying disease, then you explore it, and there's a lot of underlying disease that can cause it, such as malignancies. And if they don't, then this is something called membranous nephropathy. Now, primary membranous nephropathy has an associated receptor targeted. What is that receptor? Phospholipase A2 receptor. Good. Okay. So they commonly have anti-phospholipase A2 receptor antibodies. Okay. Good. That is in membranous nephropathy. Now, for treatment of membranous nephropathy is usually treat them conservatively. In any patient, I'll tell you now, that any patient with proteinuria, you can give them ACE inhibitors and ARBs, and it helps. Another class of drugs you can also give them, and this is more when we talk about diabetic nephropathy, is SGLT2 inhibitors. And then if this doesn't work, then you go to the next step. You can give steroid and so on and so forth. But in these patients, you need to give them anticoagulants. Okay? Now, the indication to actually treat them depends on the severity of the patient. Do you need to actually know the details of that? No. Okay? They won't test you on it. But in simple terms, you treat them conservatively. It can go on its own. However, you see this, you assess the severity of these patients. But you treat them conservatively, meaning that you just give them ACE and ARBs to decrease the proteinuria. There's some element of hematuria that can happen as well. You decrease that. And this will help the patient. It will remove the edema, remove all that stuff. Okay? So that's basically the management of membranous nephropathy. If this doesn't work, then you go more extreme treatments, such as steroids and then immunosuppressants. Okay? Now, what's important for you is how to identify this on these three images. Number one is on light microscopy. What do you see? Very simple. Thick basal membrane, good. On electron microscopy, what do you see? Very characteristic. Electron. Spikes and dome appearance. So this is the endothelium. This is the basal membrane. This is the epithelium. You can see that there is spikes and dome. Spikes and dome. Tamam? This is subepithelial deposits. Okay? And you can see obviously some granular pattern that's occurring here. Okay, this is membranous nephropathy. Now, we took this last block. Well, if you have a patient with malar rash, or this is a discoid rash, with a patient with arthralgia, serositis, anemia, what do they have? SLE. Good. Now, SLE can affect the kidneys in around 50 to 70% of the time. Okay? And this is what we call lupus nephritis. You already know SLE in detail. You know how to diagnose it. You know what the antibodies are. I will not tell you and test you again. But just a quick recap, you have ANA as a sensitive antibody, the first one you order. Then you have anti-double-stranded or anti-Smith antibodies as the more specific ones. Then we have lupus nephritis. Lupus nephritis has different classes depending on how severe the patient is. Okay? Now, the way we differentiated clinically is class 1, class 2 is together, class 3, class 4 is together, class 4, 5, and 6 are together. In terms of how we want to treat the patient. Class 1, class 2 has minimal mesangial disease or mesangial proliferative disease. In these patients, they are asymptomatic. Okay? So they don't have any symptoms at all. When do we start suspecting if they have symptoms? Easy. You do urine analysis, you see proteins. If I see proteinuria in a patient with SLE, a known case of SLE, I will do one quick thing, biopsy. Because you need to treat it because nephritic syndrome, or sorry, not the nephritic syndrome, lupus nephritis is not as easy to treat, okay? So you need to give them more therapies, okay? Then we have class 3, class 4. Class 3, class 4, the way you differentiate it by this word. If it affects less than 50, it's focal. If it affects more than 50% of glomeruli, it's diffuse. Easy. Then class 5, class 6 is the severe ones. This is membranous glomerular disease, similar as membranous nephropathy. And then you have advanced sclerosing disease, which you will try to give the patient or send the patient. Obviously, the patient will be on dialysis, and you try to do transplant for these patients. Okay? So that's basically this. How will the patient present? These two are asymptomatic. These two will have elements of hematuria plus proteinuria. Okay? Here is flat out proteinuria and nephrotic syndrome. And obviously here is end-stage renal disease. Okay? That bit that I explained in how they present is a bit advanced for you. But what you need to know is how to differentiate them by description. Okay? Very easy. If it's like this, for example, if it's affecting a segment of the glomeruli, think of it as FSGS. Okay? It's not affecting all the glomeruli, less than 50%. And the patient with SLE, what stage is this? 3. Easy. Focal proliferative. On the contrary, if it's affecting more than 50%, 4. Now, what do we call this characteristic appearance? Wire loop. Okay? Wire looping. This is in diffuse proliferative. I will usually say DPGN, diffuse proliferative glomerulonephritis, but it's SLE, diffuse proliferative. Okay? Same thing. You can see characteristic wire looping. If they test you on any of these grades, it's usually grade 4. Okay? SLE. Again, grade 3 is focal. Okay? So it will only affect less than 50% of glomeruli. If it's more than 50, it's diffuse. If you look at the light microscopy, you can see characteristic wire looping, okay? And you can see here subendothelial deposits. Tom? Now, the class 5 is similar as the membranous nephropathy that we looked at. Very similar. Now, for SLE treatment, I won't go into details because we cover this in MSI, but somewhat, yani. But what I want you to remember is in all patients with diagnosed SLE, we start them on what drug? Do you guys know? What is the first medication that we will give them? Hydroxychloroquine. Good. Okay, hydroxychloroquine. This is the #1 drug we give from the start of the patient's diagnosis. We start them on this. Okay, it does not matter how severe the patient, how severe the SLE is. We start them on it. Okay, and we keep them on it. Now, if they have mild disease, we may give them glucocorticoids, just as an adjunct therapy. Now, what's important is as it gets more severe, we start adding all these drugs. What I really want you to remember, from what I remember, is MMF, mycophenolate modafinil, is what we give in SLE nephritis. Okay? I could be wrong in this, but I'll double check, and if I'm wrong, I'll correct myself in the urology one, inshallah. But I think it's MMF. Tamam? This is how we treat SLE. As it gets more severe, we add more immunosuppressants. That's as simple as it is. Tamam? Now, you have a known case of diabetes. A few years later, patient presents with microscopic proteinuria, or albuminuria, whatever. What is this? Diabetes. Okay, diabetic nephropathy. Is this only affecting the membrane, or is it also causing KW lesions or sclerosis? What's being affected in this case? In this patient, in this image, membrane only. Okay, you can see only in the membrane. Why is this so? This is the early signs of diabetic nephropathy. In early stages of diabetic nephropathy, it will affect the basal membrane only. Why? Is because glucose will deposit there. When will this happen? So in patients with diabetes, we have certain sets of complications that will occur. We have two broad classes of complications. We have microvascular and macrovascular. Tamam? Macrovascular is stuff like MI, strokes, peripheral vascular disease. Ignore them. Microvascular is 3. Eye, retinopathy, legs, neuropathy, or nerves in general. And lastly is nephropathy. Tamam? These three will somewhat happen at the same time. So you'll need to see if the patient also has retinopathy or neuropathy. Okay. Now, in the case of nephropathy, the early stages of diabetic nephropathy is membranous. Okay, it will affect the basement membrane only. Tamam. Now, later on, it will start to develop more lesions like this. Now, what's happening here? If you remember in CVP, okay, if you remember in CVP, we have arteriolosclerosis, right? We have two types, hyaline and hyperplastic. If you remember, hyaline was caused by two diseases. Number one is this, diabetes. Number two was benign hypertension. Good. In diabetes, the hyaline arteriosclerosis will start to decrease the amount of blood supply going into the kidneys. So what's going to happen is sclerosis. It's going to fibrose because it's not getting enough blood. So it forms these characteristic lesions called Kimmel-Wilson lesions in diabetic nephropathy. Okay? And in hypertension, it will just cause sclerosis of the kidneys later on because of poor blood flow. Here you have two things happening. The glucose itself is depositing in the blood vessels in the glomerulus. And number two is hyaline arteriosclerosis, which will then form these lesions. Does this make sense in the case of diabetic nephropathy? Tamam. Good. Remember this image. Remember KW lesions and remember the stages of diabetic nephropathy. It starts with membrane, then forms the Kimmel-Wilson lesions, which is going to cause the nodular glomerulosclerosis. Okay, and that's basically diabetic nephropathy. Okay, now in this case over here, you have some sort of systemic disease that's depositing in the kidneys. You do Congo red stain, and you can see apple green bifurcations. Amyloidosis. Okay? Amyloidosis is a systemic disease that causes deposition of amyloid. Now, you have multiple types of amyloidosis. You have primary, secondary, and whatnot, and localized and whatnot. It's very, just don't worry about that. What you do need to know is how to identify amyloidosis, which is going to be through the stain. It will give you the stain 100%. Congruent stain that will show apple green bifurcations. Tamam? This is amyloidosis causing nephrotic syndrome. Now, that is it for the glomerular diseases. I have tables from first aid, which basically summarizes everything that I just mentioned. I don't think I missed anything, Salaha. Yeah. It's basically the same. And this is just for you guys when you're going through the slides. If you need to annotate while you go through the session, it's all here, inshallah. Do you guys have any questions for the glomerular diseases before I proceed? Do you guys want a quick break and then we go through the rest? Because we finished half, I think, by now. خلاص, so let's come back. Let's come back at 7:20. Is that okay? خلاص. Okay. So now we'll go into the tubular diseases, inshallah, and a lot of the clinical nephrology sections as well. So now there are some tubular diseases that I want you to remember. However, in my opinion, these diseases that I'm about to show you or tell you about are very low yield, like extremely low yield, extremely rare diseases that occurs. Dr. Yaqeen mentioned that it's high yield for his lecture, maybe, okay? But I'll tell you that from all of these diseases, the one that is usually commonly tested is Fanconi syndrome. Right? Now, what is Fanconi syndrome? What I want you to remember is if they ask you for a tubular defect and the patient has metabolic acidosis, it's Fanconi syndrome. Why will the patient have metabolic acidosis? Very simple, I mentioned this before, is that they will have a defect in the proximal convoluted tubule. where it will not absorb anything. So what ion will be lost? Bicarbonate. Good. What electrolyte? Bicarb. Bicarb. No more alkaline substances, so you have acidosis. Easy. طيب. They'll also have glucosuria, hypokalemia, hypophosphatemia, a lot of things because all substances will be lost. تمام. When will this happen? When will this happen? You'll have hereditary defects such as Wilson's disease, and you'll cover what Wilson's is in GI, inshallah, which is a copper defect in the liver. And then you'll have ischemia, multiple myeloma, a lot of these things that will cause Fanconi syndrome. Okay? Now, it can affect children, and it can cause growth retardation because phosphate will be lost. Okay? Now you have these other disorders which are less common and less tested, such as Bartter syndrome, Gittleman, Liddle, and then syndrome of apparent mineralocorticoid excess. Okay? Or same syndrome. So Bartter syndrome, it affects a thick ascending loop and affects this transporter. This one is autosomal recessive, and it can cause metabolic alkalosis, hypokalemia, hypercalciuria. Gittleman syndrome, DCT, affects the same thing as if you gave a patient thiazide. So if they have the same side effects as thiazide, think Gittleman. If they have the same side effects as loop diuretics, think Bartter. That's how you think about it. Liddle syndrome, the thing that differentiates it is it's autosomal dominant, and they'll have decreased serum aldosterone. Right? Why exactly? I'm not sure. Now, syndrome of apparent mineralocorticoid excess. Now, in this case, it's basically, well, you're in the kidneys, you'll have excess mineralocorticoid function. Okay? So think of it as hyperaldosteronism. So aldosterone is being hyperactive. So hyperaldosteronism cause hypokalemia and metabolic alkalosis with hypertension. Okay? Why? Is because it will increase sodium reabsorption, causes increased potassium excretion, and then with potassium excretion, hydrogen will also follow, so they'll have metabolic alkalosis. طيب? Think of it as that. Now, a fun fact is this can be an acquired defect, or it can be a result of a patient eating a lot of licorice. Okay, because there's something that will inhibit a certain enzyme, which is 11 beta hydroxysteroid dehydrogenase. Okay, and this is in licorice. The main one that I want you to remember is Fanconi. If they ask anything, I think it's going to be Fanconi. If it's anything else, just think of Bartter as if you're giving loop diuretics, Gittleman as if you're giving thiazides, Little syndrome. I hope they don't ask this one, Salaha, because there's no real way of thinking about it. And then same as if you have high aldosterone. Okay, so that's basically these tubular disorders. Now we go into the things that will 100% test you on, okay? Which is acute kidney injury. So acute kidney injury happens when you have an acute distress on the kidneys from the name, okay? Again, how do you assess for acute kidney injury? What happens in these patients is that you assess them by increase in creatinine, okay? These patients will complain to you that they are not urinating enough, for example, maybe. They are hyperkalemic. They are hyponatremic. These are the changes that will occur in these patients. More severely, they might present with uremia. Okay, I'll explain how that presents with in a bit. Tamam? Now, what's important for you is to differentiate the cause of kidney injury. Okay, so we differentiate it based on where in the level of the kidney. So you have the blood vessels going to the kidney, then you'll have the kidneys itself, then you'll have after the kidneys. Tamam? If it's affecting before the kidneys, this is what we call pre-renal. If it's a disorder of the kidneys itself, intrarenal or intrinsic. If it's after the kidneys, post-renal. Tamam? Now, what does azotemia mean? Azotemia is when you have a kidney disorder, you will have elevated what? Urea. طيب? In the case of elevated urea, but no signs of uremia, which is basically symptoms of high urea in the blood, this is azotemia. Tamam? If the patient has high urea plus symptoms, uremia. Is this distinction clear? Okay, good. Now, what will happen in pre-renal azotemia? Let's take it one by one. Number one is, how does it happen? In a patient with severe hypovolemia, okay? So for example, if the patient's going through hypovolemic shock, hemorrhagic shock, their blood volume is decreased, there's less blood going to the kidneys. This is going to cause kidney injury. Number two is a decreased effective circulating volume, or effective circulatory volume. How does this occur? Is it in heart failure and liver failure? What will you have is peripheral edema. The blood will pool in the venous system. This will decrease effective circulating volume, which is basically the volume of blood that's perfusing organs. Okay? And this is usually a large percentage of the cardiac output. If this volume of blood, majority of it now in these two disease states, are going and pooling in the venous system, will this blood go to the kidney and perfuse the kidney? Yes or no? No. So it will cause pre-renal damage, injury. The blood is not going to the kidneys. Now, what will the kidneys do in this case? That, okay, I'm not getting enough blood. What will I try to do? Two things, okay? Number one is that the kidneys itself will sense low pressure and sense low sodium. So what mechanism will be activated? RAS. Good. Okay. Now what will RAS do? RAS will cause more sodium absorption from the kidneys and cause more fluid absorption. صح? What also will be activated? ADH. Okay. To cause less diuresis, so you retain more volume. Obviously, in these two diseases, that's a bad thing that happens, which is what's causing the vicious cycles in those two diseases. But the kidneys will operate, oh, I need more volume coming to me, so I'm going to retain more volume. Okay, that's how it functions. So what will this do? If you have increased water reabsorption, okay, in the kidneys by ADH, what will this do to the urine osmolarity? Increase or decrease? Increase. It will raise it. Easy. Why? Is because it's absorbing a lot of volume or solutes or volume, water from the tubules into the blood. So in the tubules itself, it will be more concentrated with solutes. So the urine osmolarity will be elevated. Now, we said that what also gets activated? RAS. What will RAS do? Sodium absorption. So will there be a lot of urinary sodium? No. So it will be decreased. And the fractional excretion of sodium will be less, low. Now, here's this. Are the kidneys functional in this case in pre-renal azotemia? Is there a defect of the kidneys itself? No, there's no defect, so it's function. Yes. Okay. So if you remember, in the proximal convoluted tubule, do we have absorption of your BUN, of blood urine nitrogen, of urea? Yes or no? Yes. Do you have absorption of creatinine? No. So you'll have a lot of urea nitrogen getting reabsorbed because the kidneys are fine. But creatinine will not be reabsorbed. Okay? So your BUN will be high. So that will cause the ratio to be more than 15 or more than 20. Is this clear for pre-renal azotemia? تمام. Now, in intrinsic renal, it's something affecting the kidneys itself. تمام. So this is going to affect either the tubules and interstitium, and most common one that happens in hospitals is acute tubular necrosis, ATM. Okay? Then you have acute interstitial nephritis, which happens in reaction to medications, and I'll explain this. Glomerular diseases and then vasculitis and vascular diseases. In any case, now you have a defect of the kidneys itself. So the kidneys won't be able to do its function properly, which is reabsorbing stuff, for example, fluids and stuff. So what will happen is that the kidneys won't work. So you'll have pooling of fluids and solutes. Now we go into it. If you have pooling of a lot of fluids in the tubular system, because it's not functional anymore, will the urine osmolarity be high or low? Low. It's more dilute now. The kidney's ability to concentrate urine is gone. So it will become diluted urine. So low urine osmolarity. Will the kidneys be able to absorb sodium in a disease state like this? No. So what will happen to the urinary sodium? High, okay? Above 40 or above 2%. Lastly, will the kidneys be able to absorb urea now because it's damaged? No. So the ratio will go down. Does this make sense for intrinsic? Good. Now for post-renal, it's a bit different. It's something over here, okay? After you have the renal calyces, the minor and major calyces, and then it will come to the renal pelvis and then the ureter. Now in the ureter, if you have obstruction here due to stones, BPH distally, neoplasm, congenital anomalies, whatever the case is it will cause backflow of urine. So backflow of urine, if you remember in the glomerulus, you have the hydrostatic pressure in the Bowman's capsule, if you remember that. It will go up. So what will happen? Will filtration happen normally because of the increased pressure inside the tubules? No. Okay, it will be less. So it will cause a set of diseases that occurs, or a set of like variations to the normal values. It will decrease the GFR, so creatinine will go up. Initially, this ratio will be high. Why? Is because it will push the BUN in the tubules. It will push it and cause forced reabsorption. Later on, as the kidneys gets more, let's just say hydronephrosis, if you want to call it that, or more congested, it will disrupt this function, and then the ratio will go down. For these variable numbers, you don't need to know them, but you need to identify these two, which is pre-renal and intrinsic renal, how to tell the difference. Post-renal, it varies depending on the stage, okay? That's why you don't need to know this. Is this AKI concept clear? Good. Will you use GFR to assess AKI? No, good, perfect. Will you use it for chronic kidney disease? Perfect. Down. Now, you have this patient who was hospitalized, later presented with acute kidney injury, signs of uremia, signs of hyperkalemia, signs of whatever, hypertension, anemia, whatever. You look at the urine analysis and you see this. What's happening? Acute tubular necrosis. Good. What type of casts will you see here? Muddy brown granular casts. Perfect. Good. So acute tubular necrosis happens due to two things, either toxins or ischemia. Okay? Simple. And we'll go into the difference between them. Here in this case, this is acute tubular necrosis. This red area is the necrosed area of the kidneys itself. Now you can see some of the, for example, the necrotic changes, for example, very hyper eosinophilic. Here you can see changes, nuclear changes. And then here you can see dumping of the tubules, of the damaged necrotic tubules into the lumen itself, which will form these casts. Okay? That's basically ATN. Now, ATN will be caused by usually it's two things, either ischemia or toxin induced. Now, what's the difference between them? Tell me, if there is non-continuous skipped areas in the nephron, is this ischemia or drug? This is ischemia. Good. Why is that so? Is that the blood supply is variable, okay? It's not gonna affect, it's gonna affect one place more than the other. تمام? And it's usually the proximal tubule and the thick ascending limb of the Henle loop. In the case of this one, which is toxin mediated, it's not gonna, okay, I'm gonna affect this area more than this area. It'll just affect it all continuously because it's toxin. So it's not gonna make a difference where I'm gonna affect it. It's just gonna affect it. So in this case, it's continuous. So if it's continuous, it's toxin mediated or drug mediated. That's basically that. Now, ATN, some things I want you to remember is that it's one of the most common causes. It is the most common cause of like AKI in hospitalized patients. Now, it has three phases. Firstly is the inciting event, which is in the first 48 hours. It's when the actual damage occurs in the kidneys. Then two phases occurs afterwards, maintenance and recovery. Now, maintenance is where the kidneys are now damaged. It's not going to do its function properly. So if a kidney is damaged, it's not going to do its function properly. Will it produce urine? No. Good. So you'll have oligouria. Tamam? Now, that's one of the functions. Number two is, will it be able to excrete potassium? No. What will follow potassium as well? Hydrogen. So you'll have hyperkalemia and metabolic acidosis that occurs in the maintenance phase. Also importantly is the urine will basically wash out all the toxins from the body. What's a very important toxin? Urea. So you'll have uremia and signs of uremia. What are signs of uremia? For example, encephalopathy, altered mental status, vomiting, nausea and vomiting, pericarditis, which is very important, uremic frost, which occurs around the eyes, I believe. So these are the signs of uremia. تمام? And this is symptomatic uremia. Azotemia is just urea is high. Okay, good. Later on, as the kidneys recover, why do they recover? Is because the tubules can regenerate. Okay, the tubular cells can regenerate. So you'll have the recovery phase. Here, it's the opposite. Since they're now recovering and now functioning, it will hyperfunction. Okay, to compensate for whatever happened in the last 3 weeks. So what it will do is it will cause it polyuria, a lot of urine formation. In this case, it will wash out all the electrolytes in your body. So you'll have severe hypokalemia and wasting of other electrolytes and minerals such as phosphate, magnesium, calcium, everything. Okay? Are these three phases clear? The most important is these two that you need to identify the differences of, because they will ask you what is maintenance or recovery. So then you have just basically what causes ischemia or what causes nephrotoxic effect or whatever. It's basically secondary to decreased renal blood flow that will then lead to ischemia of the tubular cells itself. So for example, if the patient has renal artery stenosis, okay, and suddenly they had hemorrhagic shock, they already baseline don't have enough blood going to the kidneys. Plus hemorrhagic shock, ischemia, just acute ischemia to the kidneys, okay? Nephrotoxic, it's because of toxic substances such as medications. Aminoglycoside is a very important one. Ethylene glycol is another important one, and then uric acid and tumor lysis syndrome, as we covered in hem-onc, rhabdomyolysis, and so on and so forth. Yes, you do have a risk of alkalosis in recovery phase. Yes. Think of it as the opposite of maintenance. The complete opposite. Okay. Now, you have a patient. They had, for example, migraine or headache, and you gave them NSAIDs. Later on, developed AKI, acute kidney injury. When you do urinalysis, you see these casts, and you see these cells specifically in the urinalysis. What is this disease? Acute interstitial nephritis or tubulointerstitial nephritis. What type of cells will you see here? Eosinophils. What type of cast is this? WBC cast. Excellent. So this is acute interstitial nephritis or tubulointerstitial nephritis. This is disease, acute kidney injury that happens to the kidneys when you have or when you're taking drugs. And there are a certain set of medications that causes this, such as sulfa drugs, antibiotics, NSAIDs, and some other ones as well. I forgot. Rifampin and diuretics, okay? Which is this mnemonic, and PPIs. Okay, these medications are nephrotoxic and it will cause acute interstitial nephritis. And the hallmark of this is eosinophils. Okay, that's basically this. Okay, acute interstitial nephritis. Now we'll go into medications, and these diuretics should be very easy for you guys to know as you took them already before. Okay, you took them in the context of CVP, so this is just a repeat of it. But I'll explain some of them that weren't explained before. So for example, carbonic anhydrase inhibitors, I believe it was explained to you before in the context of glaucoma, okay? In HNS, exactly. So it inhibits carbonic anhydrase, and then this would cause inhibition of the retention of sodium and bicarb, and this acts mostly on the proximal tubule. This isn't commonly used as a as a diuretic. It's usually called, we usually use it in glaucoma and something that's not written here, but in intracranial pressure. If we're trying to decrease intracranial pressure, not rapidly, such as when you use mannitol, but in other things. So, for example, if a patient has some certain disease called idiopathic intracranial hypertension, we use acetazolamide. They cause metabolic acidosis, tinnitus, which is ringing in the ear, and so on. Okay. Now, mannitol is an osmotic diuretic, meaning is that just having the drug in the tubule itself will retain a lot of fluids. Okay, we'll bring it all into it. This is why we give it IVs, because if you think about it, if you give it orally, um, it's going to cause GI effects because it's the same thing. It's going to cause osmotic effects in the GI. تمام. Now, what will it do in the kidneys itself? Once you give it in the bloodstream, it will suck up all the blood from the interstitial space into the bloodstream. So this will initially cause hyponatremia. Then it goes to the kidneys, and in the kidneys, it's going to cause the opposite. Now all the blood will go to the kidneys, and it will cause diuresis. So this is going to cause hyponatremia later on. تمام. And this drug, usually we use it when we try to reduce intracranial pressure very fast. Okay, very fast. So for example, if someone had cerebral edema and we want to decrease this edema very fast, we use this. In other cases, we don't really use this. For example, in the cases of cardiac failure, pulmonary edema, we don't go for this at all. Now, why do we not use it in cardiac failure and pulmonary edema is this concept over here, which is the dilutional hyponatremia. Once we give the drug, it will suck up all the blood from the interstitium into the blood. So it will worsen cardiac failure and edema. It will worsen it initially. So why would we give this? We don't. That's those two osmotic diuretics, basically. Now, loop diuretics, we covered this mostly in CVP before, but it affects the sodium-potassium 2-chloride channels in the ascending limb of the loop of Henle. Now, these drugs are very efficacious in the case of congestive heart failure with pulmonary edema. We use this drug to basically wash out the pulmonary edema, okay? It's used IV in most cases, and it's the drug of choice that we use. We also you can use it in the case of hypertension, but it's not really used, okay? So that's basically that. Now, what are the side effects? It's very important is hypokalemia, hyperuricemia, and autotoxicity. These three I want you to remember by heart. If you have a patient with hyperuricemia, gout, plus autotoxicity in the ears, this is loop diuretic effect. Tamam? This is what they'll test you because you already were tested on these drugs before in CVP. That's why I'm not going to go into detail because you already know these medications. Thiazide medications, very easy. Where does it affect? What receptor, firstly, or what channel? Sodium chloride, where? Distal convoluted tubule, good. This is one of the cornerstone medications we use in hypertension. One of the best medications. Another thing is if the patient has hypercalciuria. What does that mean? Is that the patient has high calcium in the tubules, in the kidneys, meaning that the patient has a lot of frequent kidney stones, okay, which are calcium-based. What do you do in this case is you try to reduce the amount of calcium in the tubules itself, okay? How do you do this? Is you give thiazides. Thiazides will inhibit calcium excretion in the urine, okay? So this will decrease the amount of calcium that occurs in the tubules or in the kidneys itself, hence decreasing the risk of nephrolithiasis or kidney stones, okay? At the same time, if you have a patient with osteoporosis, this is one of the medications that you can give. If they have osteoporosis plus hypertension, you give this medication. Just a side note. Now, other side effects is hypokalemia and hyperglycemia and hyperlipidemia. This is thiazides, basically. Now you have potassium-sparing diuretics, which affects the collecting duct usually, and it binds the mineralocorticoid receptors, and this antagonizes the effect of aldosterone. Okay, that's basically that for both of these medications. This one will kind of not do the whole aldosterone effect. It will inhibit the sodium, the epithelial sodium channels, which are located in the luminal side of the collecting duct. and just it inhibits this effect directly. An important side effect usually described in patients taking spironolactone or eplerenone is gynecomastia. Okay, and it's usually in males. Now, conivaptan is an inhibitor of the ADH. So in this case, you will no longer absorb fluid. You'll have increased diuresis. That's basically the diuretics. It's very simple for you guys in this state because you took most of these when you studied CVP. So it's just a quick review. What is important is knowing when to use certain medications. Okay. So for congestive heart failure and pulmonary edema, we use loop diuretics to quickly remove the fluid volume. Okay. Hypertension, thiazides, as I mentioned, is a cornerstone drug for the treatment of hypertension. Potassium-sparing diuretics, usually later in the treatment of hypertension. Kidney disease, use osmotic or loop. Nephrolithiasis, as I said, because thiazides inhibit calcium excretion, cause reabsorption. Then we give thiazides for nephrolithiasis. The osmotic ones are, for example, mannitol. Hepatic cirrhosis, you'll understand why exactly we use spironolactone when we talk about it in GI, inshallah. Edema, loop, diabetes insipidus, thiazides, these all I mentioned, osmotic or carbonic anhydrase inhibitors. These are the diuretics. Now we go into a complicated part of nephrology, which is the clinical nephrology. And now we're going to go over electrolyte disorders, acid-base disorders, and chronic kidney disease. Okay? Here is where the fun kind of starts, unfortunately. So now let's talk about electrolytes. Okay? The two electrolytes I want you to know by heart are sodium, potassium. So for sodium and potassium, sodium firstly, is it usually intracellular or extracellular? Tell me this. Extracellular. Potassium, intra or extra? Intracellular. Good. The normal sodium levels are in the hundreds. 135 to 145 is the normal sodium levels in the blood. Why? Is because it's mostly extracellular. Potassium is very low amounts in the blood, which is usually 3.5 to 5, I think. Somewhere, or 4.5, very narrow range. But that's interesting because most of the potassium is intracellular. Okay. Now, sodium, if it's below 135, causes hypernatremia. More than 135 causes hypernatremia. Will you tell the difference between them in terms of clinical manifestations? Not usually. It's very hard to tell the difference because they overlap. So I don't want you to know the difference in hypo versus hypernatremia by clinical manifestations. Almost impossible. What I do need you to remember is the causes of hyponatremia and hypernatremia, as we'll discuss in the later slides. Potassium, however, is different. Potassium, I want you to remember two organs, muscles, and it'll cause weakness or fatigue, okay? Whether it's hypo or hyper kalemia. Number two is the heart, okay? And this is where remembering potassium's effects is easy. So potassium, if you remember in the heart, does it cause depolarization or hyperpolarization? Repolarization. Repolarization or hyperpolarization, okay? Repolarization is a better term. Repolarization. So it brings it back to the membrane potential. Now, in an ECG, what is repolarization? What in the ECG is repolarization? You have the P wave, Q, R, S, and then T wave. So now think with me. Is if you have hypokalemia, will repolarization be faster or slower? Slower. Think of it logically. As you don't have enough potassium anymore, intracellular, the repolarization will take longer. So what will happen is this T wave, will it become more narrow and peaked, or will it be flat? Flat. Good. So if you start seeing flattened T waves on an ECG on a patient with muscle fatigue and spasms, you think hypokalemia. Tamam? Now in hyperkalemia. In hyperkalemia, you expect now, will repolarization be faster or slower? Repolarization. Faster. So the cardiac action potential will return back to the basement membrane much faster. Tamam? So the T wave will become peaked, will become like this. Tamam? Very peak T waves. What's the dangerous thing about this? If you're not giving time for the heart to repolarize in the basic way that it does, is that your heart rate will go faster and faster and faster and faster. What will this predispose to? Ventricular fibrillation, VFib. Okay? It will keep pulling it, and then flat. Tamam? This is why it can cause these arrhythmias or VFib. Okay, and I'll explain the actual changes that happens in hyperkalemia in a separate slide, because it's very high yield to remember this. Okay, so that is potassium. Now, don't worry, I'll go over it one by one in a separate slide. Now, hyponatremia. Hyponatremia, what I want you to remember, not the symptoms of hyponatremia, but rather how to diagnose a patient with hyponatremia. Firstly, you establish from the level of sodium in the blood is that they have below 135. Okay, this diagnoses a patient with hyponatremia. This tells you that the patient has hyponatremia. The first thing you want to do is you want to see if they have something called pseudo hyponatremia, which is basically you don't need to go into detail, but because of other solutes in the blood, such as glucose and stuff like that, if it's too much in the blood, it will tell your analysis that this patient has low sodium because other solutes are high. Okay? This is pseudo hyponatremia. Don't worry about that. You established that this patient has true hyponatremia now. The thing that you need to remember or need to figure out next is this hyponatremia mediated by ADH or not? Okay? How do you know this? So in the case where you have ADH present, okay, what is the function of ADH? It will reabsorb fluids, okay, fluids from the tubules, okay? So you'll have water retention. This water retention will cause hyponatremia because it dilutes the blood itself. Tamam? So you establish that this patient has high urinary osmolality. Why? Is because you're diluting the blood and concentrating the urine from the ADH's effect. It's concentrating the urine. So you establish now that this patient has high urinary osmolality, which is ADH dependent. Then you look into it more detailed. You look at the urinary sodium. Now, in the case where you have low perfusion of the kidneys, what's happening in heart failure, cirrhosis, or nephrotic syndrome is you'll have peripheral edema. As I said, in the pre-renal azotemia, you'll have decreased effective circulatory volume, which will trigger the kidneys to activate two systems, RAS and ADH. ADH will cause more fluid reabsorption, okay, which will cause the high urinary osmolality. And another thing is it will cause more sodium reabsorption from the kidneys. Hence why you have low urine sodium, okay, in patients with low perfusion because of activated RAS and activated ADH. If you look into a good perfused kidney, where the kidney is getting good amount of blood supply, okay, will RAS be activated? Will you need RAS? Yes or no? No, okay, it's perfused normally. So what's happening is why is there ADH? You have SIADH. Okay, there's ADH being secreted from somewhere that's causing that fluid restriction or fluid reabsorption, okay, into the bloodstream. However, if you look at the urinary sodium, it's high. Why? Is because RAS is not being activated. So you have urine that's being excreted normally. This is seen in SIADH, which is syndrome of inappropriate ADH secretion, which is seen in CNS lesions and pneumonia. Remember these two. Again, low perfused kidneys will cause two systems to be activated, RAS and ADH. RAS will absorb more sodium, hence causing low urinary sodium. And number two is ADH will cause more fluid reabsorption, concentrating the urine, diluting the blood, causing hyponatremia. Is this pathway clear? Tamam. Now we go into dehydration. Okay. When you are dehydrated, tamam, you're not intaking a lot of fluid, or for example, or you are releasing a lot of fluids. Tamam. In this case, what's it called? Let me collect my thoughts 1 second. Let me explain this pathway, then I'll get to where dehydration is. Okay. So in this case, where you establish that this patient has ADH independent, how is because low urinary osmolarity. Tamam? So in the cases of low urinary osmolarity, this tells you that ADH is not being activated. But why does this patient have hyponatremia? Okay. Now, why this patient has hyponatremia is 3 different scenarios. Number 1 is low urinary sodium. The patient themselves have normal volume status, but they are not intaking sodium. So, hyponatremia. Tamam? Now, number 2 is polyuria polydipsia. Now, in this case, you have a patient who's drinking a lot of fluids, causing dilutional hyponatremia. Okay, drinking a lot of fluids. When you drink a lot of fluids, what will happen is you'll have polyuria. Makes sense. Your kidneys will release it. Hence, will ADH be activated in this case since you're drinking a lot of fluids? No. Okay, so you'll cause polyuria, polydipsia. Last one is renal failure. Now, if I remember correctly, and I could be wrong here, is in the cases of dehydration, you do have ADH activation, right? This is the part that gets tricky for me, Salaha. Yeah, you do have ADH activation. Okay, so it's ADH dependent. Normal response. You try to retain one. Tamam? Don't remember this, remember these. But these, you need to be very clear on why this has low urinary sodium because RAS is activated, here it's high. This is hyponatremia. Okay, simple, inshallah. You'll be tested if you get tested on this. If is a big word in here. It'll be most likely to differentiate these. Okay. SIDH of patient pneumonia or CNS lesions. You do urinary sodium is high, then you'll diagnose them as SIDH. Simple. Down. So stuff like this. On the contrary, you have hypernatremia. In hypernatremia, you could have it due to water loss. Okay. So water loss is, for example, if you have diarrhea and whatnot, is because you're releasing a lot of fluids. If you think about it in the bloodstream, sodium will be high because of solute effect. The osmolarity will be high because you'll have sodium that's being retained and you'll have water loss. What's also being activated in this case in water loss is RAS, causing more sodium reabsorption. And this is seen in both cases in diabetes insipidus and GI losses. Okay. Now, in diabetes insipidus, what's happening is this. In diabetes insipidus, you have a defect in ADH function. Whether you have complete absence of ADH, which is in central diabetes insipidus, or in lack of response of ADH. So what's happening in this case in your patient is they'll have polyuria. Okay, they will not be able to control their urination anymore. They will have polyuria because they have either lack of ADH or lack of response to ADH. So what will happen to the concentration of sodium in the blood? Up. Okay. What will be activated to cause more sodium retention? RAS. Okay. That's basically that. Osmotic diuresis, as I mentioned in the beginning, is when you give mannitol or even diabetes in the beginning. Now, mannitol initially will cause hypernatremia, then hyponatremia, as we mentioned why. Or sorry, the opposite. Initially, it will cause hyponatremia because of dilutional effect, then hypernatremia because it gets you'll have diuresis. Now, in the cases of diabetes or mannitol and the level of the kidneys, it's an osmotic effect. So it will suck up more volume into the tubules and gets excreted as urine. In this case, the blood itself will become more concentrated with sodium, causing hypernatremia. Another thing, very self-explanatory, is if your patient's taking a lot of sodium. Okay? And that's basically this. You don't need to remember why this happens. This is sodium, any electrolyte issues in a nutshell. What you need to think about is how the body responds to certain diseases to cause hypernatremia. Okay? And why the patient has hypernatremia. Will you get tested on this? It's super low yield for your level to get tested on this. Okay? How do you treat hyponatremia and hypernatremia? So hyponatremia treatment is depending on if it's acute or chronic. Okay? So acute treatment of hyponatremia is very straightforward, is you give them hypertonic saline. Tamam? What is hypertonic saline? Hypertonic saline is 3% normal saline. What does that mean? Is that you have a lot of sodium solutes in the saline itself, in the fluid that you're giving the patient to fix their hyponatremia. This is in acute. In chronic hyponatremia, you need to infuse the sodium, normal saline, like normal fluid, at a specific rate, which does not exceed 6 to 8. Like there's a specific rate, which is 6 to 8. Okay? Just remember this number. Why is this so? As if you remember from neuro, if you treat hyponatremia very rapidly, what will occur? Locked-in syndrome. Good. The central pontine myelinolysis. Okay? Good. So hence, in acute hyponatremia, you'll treat them with hypertonic saline and it will fix it fast, basically. But in chronic, they already had a baseline low sodium, and you treat them quickly, they'll present with locked-in syndrome. Okay, so that's why there is a specific rate, which is 6 to 8. I think I wrote this in my slide in the notes. So just read that. In hypernatremia, it's very simple, as you do fluid restriction or something. Okay, don't remember about hypernatremia. If you get tested about treatment, it's hyponatremia. Don't remember about hypernatremia. But in this case, you usually not fluid restriction. What am I saying? You give them normal saline. Okay, that's it. It treats it. Now hyperkalemia, which from all of these, this is the one that you actually might get tested on. Okay, now. Hyperkalemia, how does it happen? As I said, there's more potassium inside the cell, صح? So there is shifting of potassium outside of the cell. That's causing hyperkalemia. So for example, if you give patients beta blockers, this will cause potassium to shift outside of the cell. Why? Is because if you have epinephrine, norepinephrine that binds to the beta receptor, it will cause potassium to shift into the cell. If you block this function, potassium will shift out of the cell. Acidosis, why? Is when hydrogen is being put into the cell. What's happening in acidosis, your body trying to compensate for the acidosis. One of the functions is in the muscles itself. In the muscles, it will try to bring the acid into the cell. What's being replaced with the acid is potassium. So potassium will be outside of the cell, hydrogen will be inside the cell. This is a compensation method to acidosis. So hence, in acidosis, you'll have hyperkalemia because of this. Digoxin will also cause it. Lysis. So for example, remember in tumor lysis, if you have potassium inside the cell, if you break the cell, potassium will be released. Hyperosmolality is because of solute. It will just follow it. And then succinylcholine will cause muscle breakdown, rhabdomyolysis, as a side effect. And this will cause hyperkalemia. So now, in the cases of hyperkalemia, what will happen is the patient will have muscle fatigue, muscle weakness. So what will the patient present as that? What's dangerous is the cardiac manifestations. They won't tell you, oh, I feel something in my heart. No, they'll have ECG changes that's rapid and will be life-threatening if you don't detect it fast. So when does this happen? Is I want you to remember a magic number, which is not 6, it's 6.5. If it's above 6.5, it will start to cause cardiac manifestations. What are these cardiac manifestations? Tall T waves, okay? Then it will form a widened QRS complex, okay? Very tall T wave. And then it will basically think of it as pulling the whole thing like this. So it will cause sinusoidal pattern, okay? It kind of pulls the two waves together or apart. This is in severe hyperkalemia. Tamam? How do you treat these patients is you try to cause shift of potassium back to the cell. How do you do this? Think about it. You can give albuterol, beta agonist, puts it back into the cell. You can give them, for example, insulin. Insulin will cause low sugar, so it will bring it inside the cell. Good. You can also give them calcium gluconate, which basically stabilizes the heart. Okay? And then you can give them fluids and whatnot. This is the treatment of hyperkalemia. You try to intracellular shift the potassium back in, which is by insulin, dextrose, albuterol, and stuff like that. And number two is you try to protect the heart. You protect the heart at all costs. The drug of choice is calcium gluconate. Okay? Which, when do we give it? I don't think you'll be tested on it, but in case, is if you have a potassium level of more than 6.5, you give calcium gluconate to protect the cell. Okay? Is hyperkalemia clear? Cool. Now, hypokalemia is the opposite, and we talked about the cardiac manifestations already. It's just flattened T waves. Now, in hypokalemia, the one major thing that I want you to remember is firstly, it's the opposite of this, whatever this is. Okay, so whatever happens here, so for example, if you get beta agonists of a patient asthmatic, they'll have hypokalemia. Alkalotic patient, they'll have hypokalemia. So think of it as the opposite. Another thing is high aldosterone. Yeah? High aldosterone will cause more potassium secretion to occur. Now, what will this cause? A triad. Hypertension, hypokalemia, and metabolic alkalosis. This is a triad driven by aldosterone. The rest of this don't remember, but it's just for you to remember. Aldosterone will cause more potassium to be secreted. What will follow potassium? Hydrogen. So think metabolic alkalosis. And what will aldosterone also do is it will cause more sodium and water retention, hence causing hypertension. That's basically hypokalemia for you guys. And you don't need to, I don't think you need to know all of this. This will be described to you in detail in EndoRepro. But it's very simple and straightforward. Until now, all good? Before I go into acid base. Now for acid base, okay? Honestly, the probably most confusing and difficult concept of nephrology to get the first time, especially with the way it is usually described to you guys, okay? But I want you to simplify it, inshallah, as much as possible and try to think about it logically. Now, in your body, I want you to remember there's two acids and one base, okay? Just to make it simple. The two acids in your body is something that's firstly H plus, the actual acid, hydrogen. Number two is carbon dioxide. These two, remember those two. The base that I want you to remember is bicarbonate. If you have imbalance of these two, you'll have an acid-base issue. Now, we want to look at is how do you approach to any patient with an acid-base issue. Okay, so first thing is you check their pH. Now, the pH range is 7.35 to 7.45. If it's less than 7.35, what does this indicate? Acidosis. If it's more than 7.5, alkalosis. Good. So now in acidosis, okay? As I said, you have two acids, H plus and carbon dioxide. So if you have an increase in carbon dioxide, will this cause acidosis? Yes. If you have increase in hydrogen, will this cause acidosis? Yes. If you have a decrease in bicarb, will you have acidosis? Yes. So you have a changes of all of these three that will cause acidosis. Now, the next thing after you establish this patient, okay, now I can see that pH is 7.3. Acidosis, yes. Now I want to see what type of acidosis they have. If they have an elevated PCO2, carbon dioxide, which is normally 35 to 45. If it's above 45, or 44, this is respiratory acidosis. Easy. Okay, there's high amounts of carbon dioxide in the body, hypercapnia, causing respiratory acidosis. When will you have respiratory acidosis? I want to just to quickly remember some of the causes, okay? Hypoventilation is the most important one. When will you have hypoventilation? I want you to remember COPD, okay? COPD, because if you get a patient with COPD, most likely they'll have respiratory acidosis. Number two, obesity, okay? There's something called obesity hypoventilation syndrome. You don't need to remember it. You don't need to know how it looks like, but think about it. Is in obese patients, they'll have low inspiratory effort, low respirations. So they'll have hypoventilation by default. So respiratory acidosis. Tamam? And then you'll have opioids, which will cause respiratory depression and some other stuff. Tamam? This is hypoventilation that causes respiratory acidosis. When you're not ventilating enough, the carbon dioxide gets trapped in the body. If you're hyperventilating too much, you're releasing so much carbon dioxide. This causes what? Respiratory alkalosis. Tamam? Good. We're fine till now, inshallah. Now, let's just say you saw CO2 and it's 38, which is in the normal range. Now you look at bicarb. Bicarb, let's just say the normal level value is 24. If it's less than 24, what do we call this? If it's less, acidosis, metabolic acidosis. Good. Now we think about metabolic acidosis. Metabolic acidosis, the way I want you to think about it is either you have high hydrogen, which in itself is multiple forms. You just have high acid. Or you have low bicarb, or both. Tamam? So now, how do you assess what type of metabolic acidosis this patient has? Is by checking the anion gap. Tamam? How do you check the anion gap? Is sodium minus chloride plus hydrogen plus bicarb. Usually in these patients, now we'll take it here, okay? Is if a patient has metabolic acidosis due to low bicarbonate, what will happen to the anion gap? Is this chloride will go up. Bicarb will go down. So will the anion gap be normal? Yes or no? Yes. So what's happening is in metabolic acidosis due to solely low bicarbonate, there's no acid being produced, will present as normal anion gap metabolic acidosis. Why? It's because there's loss of bicarb in the tubules itself, chloride will be reabsorbed more. When chloride gets reabsorbed more, it maintains the anion gap. Okay? Now, if you have acid being produced due to some reason, okay? Some drug that you gave the patient, which is an acid, some buildup of acid in the body, what's happening is bicarb is going down, but chloride is not compensating for it anymore. What's compensating is unmeasured solutes. What is that unmeasured solutes? Acid. Okay? So will there be an anion gap? Yes. This is what we call high anion gap metabolic acidosis. To repeat, you establish the patient with metabolic acidosis. Done. We know it. The patient has low pH plus low bicarb with normal CO2. Let's just think CO2 is normal now. Okay, I know now the patient has metabolic acidosis. What's next step? I need to establish their anion gap. If their anion gap is normal, that means that there's just low bicarb. There's something causing low bicarb only. So this is normal anion gap metabolic acidosis. If there's an anion gap, that means there's a solute that's causing a high anion gap. There's something there. There's an acid that's being produced. This is what we call high anion gap. When do we see this? Is, for example, substances. Literally think of substances. Lactate is an acid. Methanol is an acid. Aspirin is an acid. Ketones is an acid. Glycols is an acid. All of these are solutes that will cause high anion gap. It will cause acidosis. In the case of normal anion gap, are any of these acids? No. What's causing it is simply low bicarb, if you want to think about it that way. Hyperchloride will cause more bicarb to be secreted. Spironolactone will cause more bicarb to be secreted. Why? Because potassium gets secreted, bicarb will follow it. Stuff like that. Potassium will be reabsorbed, bicarb will follow. Okay? It will cause acidosis. Tamam? Diarrhea, bicarb will be lost. Saline infusion, bicarb. It's just bicarb going down. Does this pathway make sense? I hope I simplified the thinking process a bit. Tamam. Good. Because quite realistically, there's a lot of these acid-based disorders you can get just by thinking of the clinical scenario without calculating anything. Then you calculate, okay? And I'll show you an example later. Tamam? Next step is, what if they have pH that's above 7.5, 7.45? They have alkalosis. If their PCO2 is less than 35 or 35, that means that they're respirating a lot. They're going through hyperventilation. They're releasing a lot of CO2. This is what we call alkalosis, respiratory alkalosis. Easy. Okay. When would this happen? Is in any state of hyperventilation, such as anxiety, panic attack, salicylates, which is aspirin toxicity. Don't remember why it happens early and whatnot. Don't worry about it. Okay. Pulmonary embolism, if you remember, you have the initial first sign of pulmonary embolism, and the most common sign is tachypnea, okay, which is increased respiration. And then pregnancy as a physiological mechanism. Then, if they don't have low CO2, they have high bicarb, okay, then this is metabolic alkalosis, and I don't want you to remember the pathway for it. It's not going to come. Tamam? Until now, are you good? Okay, because I'm going to take it next step. Tamam. Now, the process of any patient acid base, if you're disregarding the clinical scenarios and manifestations that the patient has, you need to approach them by just looking at the levels of certain of these things, okay? So the first thing you look at is you establish acidosis or alkalosis. We know how to do that now. Step 2 is establish whether it's metabolic or respiratory. Easy. So if they have low bicarb in a patient with low pH, this is metabolic acidosis. Done. Okay? If they have high PCO2 in a patient with low pH, respiratory acidosis. Done. If they have high pH with a patient with low PCO2, respiratory alkalosis, and then high pH in a patient with high bicarb, metabolic alkalosis. What do you need to do next? You need to see whether this patient is compensating properly, okay, to the acid-base defect that they have, okay? So in metabolic acidosis, you'll have high acid or low bicarb. So if you think about it realistically, is in your lungs, will you ventilate more or less? More. You have acidosis. You have high acid in your blood. What's the two forms of acid that we have? Hydrogen and PCO2 and CO2. So what do you try to do? Release CO2. It compensates for the acidity. So you'll have, realistically, in normal physiological setting, is compensated respiratory alkalosis. Okay? You're releasing a lot of CO2. This is an immediate effect. This should happen immediately. Right? It's easy to think about. If your body senses that you have high acid, what will it do is you will just increase your breathing. That's it. Immediate response. Okay? In the contrary, if you have primary respiratory acidosis, you're already hypoventilating. Now your kidneys, is it gonna secrete more bicarb or reabsorb more bicarb? Remember, what's the most important base here? It's bicarb. So you have already high acid, which is CO2. You can't really release hydrogen. It doesn't work like that. So you try to increase the base, which is bicarb. So you reabsorb more bicarb. This takes time in the kidneys. It doesn't work like this, like in compensation of metabolic diseases. So you'll have a compensated, if you have, for example, patient with respiratory acidosis, physiologically, you'll have compensated metabolic alkalosis. Next, primary respiratory alkalosis. In this case, they already have low PCO2. They already have low amount of acid. Do you want to increase the base and cause the blood to become more alkaline? No. So what do? Remove the base. How do you do that? Decrease bicarb reabsorption. Done. Okay, removes it. That's your compensation. So compensation for respiratory alkalosis is delayed metabolic acidosis. Okay? Last thing is metabolic alkalosis. Okay? Your body has already high bicarb for whatever reason. Okay? What will happen? High bicarb or low hydrogen. What will happen is you try to compensate by increasing the PCO2 to cause a balance. How do you increase PCO2? You hypoventilate. Okay? You breathe slower. This is in the case of compensatory respiratory acidosis. So, to recap, the first step is you establish the pH, whether the patient has acidosis or alkalosis. تمام? The second step is you establish whether it's metabolic or respiratory. تمام? Third thing is you check whether or not they have a compensation, yes or no. If they have a compensation, good. If they don't have compensation, then you check for, while you're checking for compensation, you're actually checking for if they have a concomitant acid-base disease. What does this mean? It's, for example, in metabolic acidosis, the response should be what? What is a compensation for metabolic acidosis? Respiratory alkalosis. If you don't have respiratory alkalosis and you have respiratory acidosis, this is what we call a concomitant disorder. Okay? I'll give you an example of when that happens. Same thing, respiratory acidosis. Usually what will happen is metabolic alkalosis as a response. How about if it turns into metabolic acidosis, or there's simply no compensation, bicarb is normal? Then it's non-compensated. This is what is the third step, which is the first step is you establish acidotic or alkalotic. Second step is metabolic or respiratory. Third step is it compensated or concomitant, or there's something else. Fourth step, which is only for metabolic acidosis, is you check for anion gap. Okay? These are the 4 steps that you do for any patient with acid-base disorder. Now, the normal anion gap, remember, is 6 to 12. It's high anion gap metabolic acidosis. تمام? Until now, yeah, don't worry. I'll explain it to you. Okay? Like, I'm going by complicated steps. Until now, are we good? Okay. Now we go over the compensation stuff. So how do we actually check for compensation? The key disease or key acid-base disorder that we want to look at is metabolic acidosis. If you get tested on anything about compensation, it's metabolic acidosis. It's the most commonly tested one. So now, here's a patient. Their pH is 7.2. Acidotic or alkalotic? Acid. Their bicarb is 10. Metabolic or respiratory? Metabolic. Done. Now, what you want to do next is, as I mentioned, you want to check if it's compensated, yes or no. So in physiology, if you have low bicarb, if you have metabolic acidosis, what should happen to the CO2? Lowers. Good. Lowers. So now, how do you check this? By doing calculations. You have a formula called Winter's formula. Winter's formula will give you the expected CO2 in this patient with metabolic acidosis. Expected. How do you check for expected? You just put this formula in, okay? So 1.5 times the bicarb in the patient plus 8 plus minus 2. So in this patient that I just mentioned to you, the bicarb was 10. So someone do the math. 1.5 times bicarb times 10. 15. 15 plus 8. 23 plus minus 2, it's either 21 to 25. تمام? Let's just say their PCO2 is 30. Is it compensated? Yes or no? Just tell me this. Not compensated. Is it a concomitant disease? Yes, maybe. What concomitant disease? Respiratory acidosis. Good. What if their expected PCO2 in this patient again was 21 to 25, right? What if their PCO2 is 18? What is this? Respiratory alkalosis. It's metabolic acidosis plus concomitant respiratory alkalosis. If their PCO2 is 23 on the dot, what does this mean? Compensated. Compensated. Okay? Until now, are we good? Does this make sense of what's compensated, what's concomitant? Okay. To give you guys a scenario of when this would happen. In a patient with COPD, what do you expect their acid-base disease to be? Respiratory acidosis. Good. Acidosis. They're retaining a lot of CO2. What if they had lactic acidosis due to any reason? What will happen to them? Metabolic acidosis. Will your lungs function enough to compensate for metabolic acidosis? Nope. So you'll have concomitant disease. Now, does it make sense? And why two diseases can happen at once? Okay, good. I'll give you another example. Okay. In a patient with diabetic ketoacidosis, okay? Diabetic ketoacidosis. What do you expect their acid-base disorder to be? Metabolic acidosis. Good. Perfect. What if, so in diabetic ketoacidosis, these patients typically present as vomiting patients. When you're vomiting a lot, what gets released from your body? What's in the vomit? Acid. So what will happen to these patients? Metabolic acidosis because of the DKA and alkalosis, both. Confusing, but it occurs. Okay? I'll give you another example. One other one is in pregnancy, you'll have something called hyperemesis gravidarum. Okay? Which means that the pregnant woman is vomiting a lot. Don't remember that, but I just wanted to, for completion. They're vomiting a lot. Tamam? If you're vomiting a lot, what happens? Acid out, so metabolic alkalosis. صح? Good. So now, in pregnancy, you have physiological hyperventilation. So what happens? Respiratory alkalosis. Metabolic alkalosis plus respiratory alkalosis. Concomitant diseases. Okay. Again, in pregnancy, you have there's a disease called hyperemesis gravidarum, which is basically they're vomiting a lot. Think of morning sickness, but it's more severe. In these cases, they're vomiting a lot of acid. Okay, acid gets released. So you'll have metabolic alkalosis. In pregnancy as well, you might have hyperventilation as a normal physiological response to pregnancy. Okay, you'll learn this in repro. In this case, because of the hyperventilation, you'll have respiratory alkalosis, but you also have vomiting, so you'll have metabolic alkalosis, two things at once. The reason why I'm telling you this, or these scenarios, is just to picture how these numbers can actually play clinically and how it happens. So you're not just memorizing numbers for no reason. Okay? These are examples of how it happens. Let's go back to the actual lecture. What you will most likely do in this scenario is they will give you a metabolic acidosis patient. Then you go on with it. You'll just say whether it's compensated or if it's concomitant disease. If they want to go nice on you, which they most likely will, and they'll just tell you if it's non-compensated or compensated. That's it. They will not ask you if it's concomitant or not. So this answers one of the people in chat, is that it can either they can test you and tell you if it's compensated or non-compensated, okay? Or they will test you and say, okay, concomitant or not. Okay? I will give you examples through scenarios. I have actual questions after I'm done with this section. Okay? Now, metabolic alkalosis. Now, these are basically other ways of doing it, of doing the calculation. I don't want you to remember this because it might be actually more confusing to remember these changes rather than knowing these equations. Metabolic acidosis, I don't want you to remember this equation at all. Just remember Winter's formula. Remember this. It's much easier to remember. Much easier. Done. Done. Now for the rest of them, you kind of need to remember it-ish. And most likely, again, most likely, they'll give you this one, Winter's formula. Okay? They'll ask you to assess compensation for metabolic acidosis. However, for the sake of completion, just remember these formulas and just plug in the numbers. Okay? Very simple. Now, whether or not the patient has acute acidosis, respiratory acidosis, that's why I say and I tell you that most likely they will not test you on these because it's hard for you as a third year to know whether or not they have acute or chronic acidosis. But for you to kind of picture it is, let's just say, in chronic respiratory acid alkalosis, think of the pregnant patient because they're pregnant for 9 months, so they'll have chronic acid alkalosis versus a patient who is presenting with a panic attack. Will they have acute or chronic? Acute. Simple. So this is somewhat way of thinking about it. Here again, respiratory acidosis. Think of this as a patient who had, let's just say, they choked on something and they can't ventilate anymore. Okay, they'll have acute. Chronic, simple, COPD. Okay, are we good till now? Tamam. Now, I already mentioned this. Okay, but for the sake of, again, repetition and completion, is the anion gap, you only do it for metabolic acidosis to assess whether or not this patient has high or normal anion gap. Usually you do it by sodium minus chloride plus bicarb. If you have low bicarb only that is occurring in normal anion gap, the chloride will compensate. Tamam? In the case of high anion gap, there's accumulation of something else, which is acidic compounds. that will cause the unmeasured ions. You don't measure this acidic compounds, hence it's causing an anion gap. Now, when do you see this? This is very important to remember, which is mud piles. Remember mud piles, okay? M is methanol, uremia, diabetic ketoacidosis, propyl glycol, iron, what's it called? Lactic acidosis, ethanol, and salicylate, which is aspirin. Okay? This is mud piles. All of these, basically, what it's telling you is there is an unmeasured acid that's causing the anion gap. This will help you in the scenario, Salah. And if they give you a scenario of a patient with lactic acidosis, like they'll tell you, for example, actually it's a bit too advanced. They'll tell you, for example, P is propyl glycol. It's I think it's antifreeze, if you remember that. Okay. Anyways, they'll tell you that's ethylene. Propyl is another thing then. I don't remember Salah. It's propyl glycol. Anyways, diabetic ketoacidosis, simple diabetic patient comes with signs of acidosis, which is, for example, nausea, sometimes vomiting. And in these patients, they have a characteristic cosmal breath, which is they try to hyperventilate to release the PCO2. And then, what's it called? They're a known case of diabetes. Then in this case, you know that's diabetic ketoacidosis. Tamam? Now, the final thing before we go into scenarios and try to calculate it together is something called delta gap. Tamam? This is a very advanced صراحة. I don't know, يعني, it's advanced and it wasn't explained properly at all. Now, in a patient that you have with metabolic acidosis, you establish they have metabolic acidosis. You establish that they have high anion gap metabolic acidosis. You want to, next step is do delta gap. Okay? What will delta gap tell you is whether this patient has only isolated metabolic acidosis or metabolic acidosis plus metabolic alkalosis or metabolic acidosis with or high anion gap metabolic acidosis with normal anion gap metabolic acidosis. Kind of confusing to think about. But I'll teach it and then give you a scenario of when that happens. Now, how do you calculate it? Actually, the next question is the scenario. Is you take the patient's anion gap, which the normal was 6 to 12. Let's just take 12 as the normal range, minus the normal, over 24, which is a normal bicarb, minus patient's bicarb. Tamam? Now, to remember this, remember minus 1 or below 1, okay? So below 1, which is all of this, 1 to 2, and above 2, okay? If it's less than 1, which is the delta ratio, delta gap, this is telling you that the patient had non-anion gap metabolic acidosis that then turned into high anion gap. Tamam? I'll explain a scenario to you. Uncomplicated high anion gap metabolic acidosis, that means that the delta ratio is 1 to 2, it's normal. That means the patient had high anion gap metabolic acidosis. طيب, what if the delta ratio is above 2? This tells me that they have a metabolic alkalosis with it. Okay? I already gave you a scenario for this portion, which is high anion gap metabolic acidosis, a diabetic ketoacidosis patient who's vomiting a lot. They will have a delta ratio above 2. Okay? However, when will this happen? Non-anion gap metabolic acidosis with high anion gap. Firstly, let's practice all of this and I'll tell you a scenario. Let's have this patient. This patient, pH is 7.2, PCO2 35, bicarb is 10, sodium is 130, chloride is 100. Let's go step by step. Number one is it acidotic or alkalotic? Acidotic. Okay. Bicarb. Is it low, normal, high? Low. So what do you think this patient has? Metabolic acidosis. What do you want to do next? Winter. Good. Fine. Now do Winter's formula. What's the formula? 1.5 times 10 plus minus, or plus 8 plus minus 21 to 25. Good. It's the same one as the one I gave you. So 21 to 25. In this case over here, is it compensated or non-compensated? Tell me this first. No compensated. Could it be a concomitant disorder? What concomitant disorder? No. Why? If it's 21 to 25, if CO2 is high, that's acidosis. Yeah, respiratory acidosis. Remember, CO2 is different. If it goes up, it's acid. Huh? That's fine. So this patient we've established has metabolic acidosis with concomitant respiratory acidosis. What do you want to do next? Anion gap. Calculate the anion gap here. 20, right? 130, 100 to it's 20. Yeah. Okay, so 20. So in this case, is it high or normal anion gap? High anion gap metabolic acidosis. Good. So what's your current diagnosis? High anion gap metabolic acidosis with possible concomitant respiratory acidosis. Yeah, that could be from mud pads. Now, as I said, if you have established high anion gap metabolic acidosis, what do you want to do next? Delta. So delta, as I said, is you take the patient's anion gap minus the normal. What's the patient's anion gap? Is 20. صح? So you minus with 12. Then you take the normal bicarb, 24. Okay. I am doing this on a trackpad, so I'm sorry. Minus the patient's bicarb, which is 10. So what's the delta gap? 8 over 14, which is, give me the actual number. 0.57. Is this less than 1? Yes. So what does this mean? Okay, they had, the final diagnosis is they had high anion gap metabolic acidosis plus non-compensated respiratory acidosis plus baseline non-iron gap metabolic acidosis. When on earth will this happen? Okay. Why did I say baseline normal anion gap? Is the delta ratio is less than 1. This tells me that it is also non-anion gap metabolic acidosis. تمام? Hagma is high anion gap metabolic acidosis, just so you know. Okay. Now, you got to be very creative to think about this type of patient. Firstly, COPD patient. Okay. So COPD patients, what will they have? Respiratory acidosis. They build up CO2. Tamam? Good. A patient who has gastroenteritis, diarrhea, what will they have? They'll have diarrhea, loss of bicarb. So what will they have? Metabolic acidosis, acidosis. They're losing bicarb. Tamam? You're not vomiting, you're losing bicarb. So is this normal or high anion gap? Normal. Normal. You're just losing bicarb. There's no acid involved. What if this patient who's been complaining of diarrhea and has underlying COPD, because of this gastroenteritis, developed sepsis? With sepsis, you have lactic acidosis. So what do you have? Metabolic acidosis, high anion gap metabolic acidosis. Why does this matter to me? Is there is a severe disease happening in this patient. This patient is decompensating fast. You need to treat them fast. They had a respiratory acidosis, which is the COPD that they had. Then they developed the diarrhea, gastroenteritis. that then moved to sepsis. Crazy case, but it happens. Do you see how this could happen? 3 diseases in one? I hope that made it so at least you think of it as so we confirmed the baseline from the delta. The delta will just tell you, and the doctor himself said if you have the delta gap, you kind of see what they had before. Okay, you kind of see if it's a baseline disease or not. Are we good? But we have 2 more scenarios, actual questions. Okay, so we'll go inshallah a bit faster now that we kind of drilled the tree. So 70-year-old woman, diarrhea. Okay. And yeah, a bunch of other stuff happening in this patient. Diarrhea daily, not vomited, type 2 diabetes on metformin. I'll explain why that's important. Obese. Now you have these sets. I want you to get it just from the sets here. Firstly, is it acidosis or not? Acid. Now, bicarb, is it low or high? Low. طيب. So you want to cross out C and A على طول. Very immediately. Now you establish that it's metabolic acidosis. What you want to do here is you want to check if they have a concomitant disease. So what formula would you want to use? Winter. Do winters here. 1.5 times this, 16. 24 plus minus 2, so it's 20. Wait, what? 24 plus, yeah, so 30 to 34. In this case, the PCO2 is higher. So, respiratory acidosis. What's the answer here? E. E is the answer. Do you know why this is happening to this patient? Good. There's 2 things. Firstly, they have underlying obesity. So I know the respiration here is high, but underlying, it won't fix it. So they have obesity. So by contrast, obesity, hypoventilation, respiratory acidosis. That's happening with this patient. We established that. How do we know that they have respiratory acidosis? PCO2, it's not going down as much despite the respiratory effects. Done. Next thing is they're telling you is they are in hypovolemia. They are they have diarrhea and they have hypovolemia due to the dry mucous membranes. Now, what's important is in the state of hypovolemia with a patient with all of these risk factors, as you think of the kidneys. Now, they are taking metformin. This is a very big stretch. I don't expect you guys to get this, but metformin causes lactic acidosis in patients with kidney injury. So this is what's causing the metabolic acidosis. What you will be tested on is stuff like this. Just this. You get the numbers, you test it. They might give you a scenario that's very simple, and you get it from the scenario. Are we good? Okay. Next. 64-year-old woman. Let's go from the numbers and then go from there. So firstly, acidotic or alkalotic? Alkalotic. Good. Now, on alkalosis, you look at firstly CO2. CO2 is low or high? Low. So what is this? What is this? Respiratory, what? Alkalosis. Good. So we will cross out nothing yet. Actually, this and this. Tom. So now you have established respiratory alkalosis. Now you want to establish whether or not it's compensated or uncompensated. Tom. So how do you do that? Is you have a formula, not Winters. Winters you only do in metabolic acidosis. So let's go all the way back here. Now, in this patient, we said that they have alkalosis. So you do this, one of these, okay? Do this one. Ignore this one. I'll explain to you why I chose this one and not this one in a second. Now let's memorize this formula, apply it here. Tell me if it's compensated or is there secondary disease? Yeah, if you do the actual thing, the bicarb will this bicarb will fit in the range. I think the normal the thing was like 20 to 24 or something, if I did it correctly. Yeah, it's plus minus 2. You also do plus minus 2, so it's 20 to 24. So it's compensated, 21. Okay, so the answer here is B. Tamam. Now, why did I choose the second formula? Does anyone know why? Why did I choose chronic respiratory alkalosis? Six weeks, good. They have anemia. They have iron deficiency anemia. Okay? In iron deficiency anemia, what's the physiological response to anemia? Hyperventilation. So they've been hyperventilating for 6 weeks. Chronic. Okay? Again, the reason why I put these types of scenarios, it's a bit advanced. But you got the answer just by the numbers. The scenarios, these scenarios will help you later on, inshallah. But like just knowing some of these things, like for example, obese, khalas, you start to suspect that this patient has respiratory acidosis. The patient's taking metformin, metabolic acidosis. And now you know how to approach any patient with acid-base disorders. Are we good with our acid base? We're done. Do you have any questions before I move on? Because I know this is the most confusing concept. Clear? Good, inshallah. Again, the questions tend to be very simple. I explained the entire concept of acid base in detail just for completion. In case they go crazy with you, now inshallah you're ready. Okay? So now let's finish it up. Let's go to chronic kidney disease. Okay? So chronic kidney disease, the first thing is the time period. How many months do we have kidney injury for to say that this patient has chronic kidney disease? 3 months. Perfect. Okay, kidney damage for 3 months. Now we want to assess one thing. What will tell me the stages of chronic kidney disease? What lab value? Estimated GFR. Good. So estimated GFR will tell me, the stages of the chronic kidney disease. Before I go to that, etiology. Okay, etiology. What is the most common cause of chronic kidney disease?
Anemia,
لا, most common cause of chronic kidney disease is diabetes. Diabetes. Then hypertension, then glomerular diseases, then some other stuff. So that is the causes of chronic kidney disease. As I said, and as you guys said, chronic kidney disease, we assess it by eGFR and we divide it into stages. So we have 5 stages. 5 stages of chronic kidney disease. Firstly, normal GFR, it's above 90. If it's 90 or 89 to 60, it's stage 2 or stage 1 chronic kidney disease. Stage 2, ignore these numbers, but stage 2, it's from 59 to 45, then 45 to 30, then 30 to 15, then below 15 is the last stage, okay? Do you need to remember these? Yes. Okay. Stage 1, 2, 3, 4, 5. 5 stages. Okay. That's it. Yes, the numbers. Yes. You need to know these numbers. If I tell you now the GFR is 35, what stage is he? 3. Just say 3. Ignore B and A and all that stuff. 3. Okay. If their GFR is 50, it's 50, it's 2. Okay. If it's 10, oh, stage 5. Now there's something else, which is this albuminuria scale, which is A1, A2, A3. Ignore this. Okay. You won't be tested on this. You will be tested on this. All right. That's chronic kidney disease. Now, important thing is in chronic kidney disease is the outcomes of chronic kidney disease or any kidney disease, what happens as a consequence of it. Now, think about it this way, is in chronic kidney disease, uh, what's happening is, firstly, in ionic levels, like ions, what's happening is you'll have, firstly, retention of more sodium. Tamam? When you retain more sodium, what's going to happen to your blood pressure? Increase. So first consequence, remember, is hypertension. Yeah. Number 2 is potassium. Is it going to be excreted properly or not? No. So what will happen? Hyperkalemia. Good. Will you have normal excretion of acid and normal retention of bicarb? No. So what will you have? Metabolic acidosis. Good. Perfect. Now, because you have a defect in the kidney's filtration, what will build up in the blood? Toxic substance, urea. So what will you have? Uremia. Good. Perfect. What is a hormone that's synthesized by the kidneys? Erythropoietin. Excellent. So if you have decreased erythropoietin, anemia. Okay, good. Which is, if you remember from hem-onc, normocytic normochronic anemia. Yeah. Uh, what else? No, yes. Calcium. Would it be reabsorbed normally in the kidneys? No. So what will your parathyroids do? High PTH. What will high PTH do? Bone resorption, which is going to cause renal osteodystrophy or the osteitis fibrosis cystica, if you guys remember from the other side. Okay, perfect. I think the brown tumors, yes. Trying to think, is there more? There should be, but no, we got all of it. All right. Know those consequences of chronic kidney disease. All that we just mentioned. Okay. How does uremia present as? Pericarditis, as I mentioned, encephalopathy, nausea, and anorexia. This is very important because uremia in itself is an indication that we do dialysis for the patient. Okay, so if they have uremia syndrome and uremia symptoms, we do dialysis, no matter what presentation of it. Tamam? I think that's that. Now, drug dosage adjustments. Now, this is a pharma lecture, which is very simple, and you'll get questions on one of these three usually. For us, we got, I think, this. But basically, in the case of chronic kidney disease or renal impairment, you just need to be very careful with the medications that you're giving the patient. Anything that is nephrotoxic and basically is alterated in renal dysfunction, you just need to be careful of. So a common drug is gentamicin, aminoglycoside. You need to be very careful with it because it's if you see this black line, it's mainly affected through the renal route. Okay, it's not affected by any other sources of excretion. This antibiotic, on the other hand, its plasma clearance is a lot, and it's basically secreted by somewhere else as well. Okay, and gentamicin, its whole clearance depends on the kidney. That's basically, they'll ask you, for example, what is this line indicating, or give me a drug that is this line, and you just say gentamicin or aminoglycoside or vancomycin or whatever. Tamam? That's how they would ask you about this. Now, for any patient with kidney disease, you'd basically either decrease the dosage of the drug itself, switch the drug entirely to something that's not nephrotoxic, so something that's liver metabolized, hepatic metabolized. And lastly is decrease the frequency of the dosage just so you don't cause a nephrotoxic effect. So that's basically this lecture. We're done. Now, for the first time, I'm including immuno in my crash course because I thought it's very simple and it's just 3 concepts that you need to remember, and we're done. Now, some transplant principles. Now, this is not specific to the kidneys. However, in patients with chronic kidney disease who's been on dialysis, or for some reason, who's been on dialysis for a very long time, or someone with acute kidney injury that cannot recover, we do transplant for them. Now, the type of transplant depends on the type of graft that we use. The graft is the tissue, basically. So we call it autograft if it's coming from the same individual, okay? So let's just say patient A is donating to patient A, to himself, okay? When do we use this is not in kidney transplant, obviously, but in hematopoietic stem cell transplant, in bone marrow, okay? The details of this you don't need to know, but just so you understand, is what we do is a patient with leukemia, we take their bone marrow, okay? We take it, send it to lab, and desensitize it, clean it from the tumors, okay? Fully clean it by radiation and stuff like that. The patient themselves, they still have the tumor, so they still have leukemia. So what will we do is full body radiation, full body chemotherapy, everything, to basically wipe out their bone marrow completely, okay? So what will this do is this patient will be severely pancytopenic, as if they'd have no bone marrow at all. Then what do we do? Once we know that the bone marrow that we took out is clean and has been reserved, we send it back to the patient. Will this minimize risk of rejection? Yes, by a lot. So this is one application of it. Then isograft or syngraft is when we have a genetically identical patient. So this is, for example, in twins. Allograft, which is the most common one, which is, for example, any human-to-human donor, okay? Now, xenograft is donor recipient from different species. A common usage of this, obviously, there's a kidney example, but a very common actual usage is in valves, heart valves. We can give porcine valves, which is basically pig valves, which act very similar to normal, to human valves. So this is just basic terms that you will get tested on. If you get any questions on immuno, it's these concepts I'm explaining. So that's one. Number 2 is when you are transplanting an organ or a tissue, you need to make sure that there is a proper match with the recipient, okay? Donor to recipient. The best donor is always sibling. Remember that. This is all I want to remember. Sibling, donor to recipient, so brother to brother, brother to sister, whatever, siblings, donating to each other is the best one, okay? They'll have less risk of mismatch. That's what I want to remember. Obviously, identical, like the same person was going to have better, obviously, but in a real sense, if you're donating kidney, you're not going to donate to yourself, okay? So it's 1-to-1 if it's like a sibling to another sibling, okay? Now, when you are donating, you need to do some HLA matching. What does this mean? Is HLA, you have 2 classes, right? You have class 1, class 2. Now, class 1, you have A, B, and C. Class 2 is you have DR, DP, and DQ. Right? Each of these will have 2 alleles. So A, for example, have 1 allele, 2 allele. 2 of them. Right? So each class will have 6 alleles. A will have 2, B will have 2, C will have 2. DR will have 2, DQ will have 2, DP will have 2. So in total, you have 12 alleles. What you need to do is you need to make sure that there is, when you have, for example, a recipient, you look at a list of donors. The one that has the least mismatches is the best donor. Okay? Now, when you are reading the HLA genotypes in these cases, you look at the alleles. Now, if I have, for example, this allele, okay? Now, it doesn't have to be in the same position. It can be in the like identical, like similar. For example, if there's 8 here and there's 8 here, we're good. If there's 3 here and 3 here, we're good. Right? So in this case over here, in this A genotype, is there a mismatch? Yes or no? Just tell me this. No. Over here, one allele. Is one allele in the recipient? Yes or no? Yes. 27, is it there? No. So this is one mismatch. Here, 8, is it present here? No. 4, is it present? Yes. So how many mismatches does this donor have with the recipient? 2. So we'll keep it in mind. Now, here, 8, is it present in this class? Yes or no? Yes. This is not a mismatch. I know it's not in the same position I did exactly, but it's not a mismatch. 6, is it there? No. So this is mismatch 1. How many mismatches here? 2. How many mismatches here? 2. So how many? 5. Good. Here, 2. Here, 0. Here, 1. How many? Good. Here, 2. 0. 2. So 4. Last one. 1. 1. 0. 2. So you have 2 donors. They are good. We good? We choose one of them. That's concept number 3 from immuno. Three counts for both. What does that mean? Yeah. Why? Like how? Interesting. No mismatches in the last one? How? Isn't 27 and 1? Ah, okay. Because of both threes, since it's here. Okay, I got you. Okay, makes sense. Like, so in this case, it's just one mismatch. So the best donor is in this case 5. Good. Actually, very good catch. But yes, since this has 3 in the allele in class A, even if it's in both, it's fine, it counts. So this is one mismatch. So donor 5 is the best donor in this case. So you take from donor 5. Tom, thank you for that, actually, mashallah. Now lastly is transplant rejections. So transplant rejections, there's 3 types that I want you to remember. You don't need to know all of these. I just love these tables. But anyways, is you have hyperacute rejection, acute rejection, and chronic rejection. Okay? Hyperacute is very rapid onset, and it's because of the patient already having antibodies against that tissue. So when would this happen is, for example, if you had ABO incompatibility in the mother and the fetus, there's some like connection there. Or that you took blood transfusion from that same patient or the recipient, then you already have pre-existing antibodies to that tissue. So you will have a type 2 or type 3 hypersensitivity reaction. Okay. And it's very acute, hyperacute reaction that causes graft necrosis. Acute usually occurs 2 weeks-ish, within weeks to months after transplantation, and it's CD8 T cell, sorry, it's CD8 cytotoxic T cell mediated, which is a type 4 hypersensitive reaction usually. Okay, I know your slides also says 2, but it's usually type 4. And this causes lymphocytic infiltrate with vasculitis and so on and so forth. Chronic rejection happens way later, and it's a type 2 or type 3 hypersensitive reaction, and it happens months afterwards, and it presents as arteriosclerosis. These are the transplant rejections. How do you prevent transplant rejections? 2 ways. Number one is beforehand, you just do proper cross-matching and HLA grouping and all that stuff. And then once you transplant the organ, what do you want to do? Do you know? What do you give to the patient? Once you transplant the organ, what do you give? Immunosuppression. Good. So the immunosuppressions, you know most of these already from MSI. So it's mostly just, again, repeat. But you have, for example, the calcineurin inhibitors, such as cyclosporin and tacrolimus. These are usually, for example, tacrolimus is usually given after solid organ transplant, such as renal transplant. Now, cyclosporine, it's a calcineurin inhibitor which blocks IL-2 transcription. Very important to remember about this is it's very nephrotoxic, and you be careful with the medications that are nephrotoxic as well. So, for example, aminoglycosides, okay? Be very careful of them. So yeah, then tacrolimus, very similar. Sirolimus, not tacrolimus, sorry. Sirolimus is the one that we use in kidney transplant. Not tacrolimus, sorry. So sirolimus is an mTOR inhibitor which blocks the T cell response to IL-2. It doesn't block IL-2 itself or block IL-2 production. It blocks the T cell response to IL-2. So this is sirolimus. It's used in kidney transplant. It's not nephrotoxic. And yeah. Then we have the anti-CD25, which is the IL-2 receptor monoclonal antibody, which is this one. Then azathioprine, which then turns into 6-mercaptopurine, which blocks nucleotide synthesis. And we already know when we use it in terms of rheumatoid arthritis that we covered in MSI. Toxicity is it causes pancytopenia and one other toxicity, which is important. Where? Which organ? The liver, okay? It causes hepatotoxicity. Hepato and myelo toxicity, okay? Remember that. So we follow up with liver function test and CBCs. Then we have MMF. Again, it inhibits IMP dehydrogenase, which is in purine synthesis. And then we have steroids, which we studied a lot till now. With that, I am done with nephro in this crash course. Do you have any questions? Stay tuned, inshallah, for the second part, which is urology. It'll cover literally everything, inshallah, in terms of tumors, cysts, bladder diseases, prostate, testicular diseases, kidney stones. There's no pharma and all the infectious stuff, inshallah, and radiology. So it's a lot of identification, and I'll be quick, inshallah. This session required a lot of understanding and me explaining, especially the acid base and electrolyte stuff. Like, Allah yafikum. Thank you guys so much.